Dear ladies and gentlemen, dear colleagues, esteemed friends, it's my great pleasure to welcome you to this International Symposium on overcoming silos in the fight against sepsis and AMR. We will have some slight changes in the opening because there's some delay for unforeseeable reasons that Bill Pullman and also the CEO of the Global Sepsis Alliance, Dr. Jashi, will be present. So that's why it's my great pleasure to welcome Professor Spranger, who is the Dean of the Charité, to say a few welcome words. Thank you for coming. And
Dear Professor Reinhart, dear Professor Horst, dear patients, dear family members of patients, dear colleagues, it's my pleasure to welcome you here at the Charité on occasion of this symposium, Overcoming Silos, the focus on sepsis and AMR. Actually, the Charité has a quite long history on infectious diseases. It was founded 1710, so more than 300 years ago, as a pest house. And then in the end of 19th and beginning of 20th century, I think it's fair to say that Charité really had a leading role in pushing the limits in infectious diseases, vaccination, and our understanding how infectious diseases work. We had a number of Nobel awardees here working, Paul Ehrlich, Emil von Behring, Robert Koch, of course, and Rudolf Virchow. And actually, I welcome you here in a historical lecture hall where also Rudolf Virchow was working, and there's a photograph where I was supposed to be on that photograph, Rudolf Virchow, at least I was told so. And Rudolf Virchow was a really fascinating person for two reasons. First of all, he established the cellular pathology, which to me is one of the basic cornerstones of modern molecular medicine. And we have the successor here of Rudolf Virchow, Professor Horst, and he's now working, I think, based on that as well, so with very modern technologies, single-cell sequencing, to again better understand the interaction of the cells and how diseases develop, order arrangements in the cells and so on. So kind of Virchow 2.0, I think. That is one part of Virchow, so he really established this modern molecular medicine. But the second part, even I think more interesting, he was also a politician, and he established social medicine as an own discipline. And as that, he had this deep understanding that both is necessary, modern medicine or modern science, and this social medicine, social aspect, politician aspect. And for example, here in Berlin, he established modern water systems and sewer systems, and that certainly had a tremendous impact on the mortality of infectious diseases as a result of infectious diseases. So, regarding and coming back to sepsis, I think both is as well important. I mean, the threat from sepsis apparently is not only that we have not appropriate treatments in many situations, but it's also that it's often recognized too late. Even if the patients are in the hospital, there is sometimes a too long delay before we start the appropriate treatment in those patients. So we also need to raise awareness for the disease itself if we want to be, in a way, successful in the prevention of sepsis. I think we need both, of course, and I think we will have some talks today about modern treatment options, but we also need the social aspect, we need the perspective of the patients. Therefore, I think this topic is really excellent, overcoming silos. Both will be necessary, and I think it's appropriate to do this here in this historic lecture hall. With this, I wish you really fruitful and interesting discussions. Unfortunately, I have to leave because we have some 100 meters away a large meeting where we discuss the future research strategy of the Charité, so that also required a little bit my attendance. But I'm confident that you will have interesting discussions. I hope you enjoy the day, and I thank you for listening. Thanks.
Thank you so much, Professor Spranger, for this update and look back on the history of Charité, but the future is why we are here and to improve prevention and the management of sepsis. So I welcome again Professor David Horst, who is the successor of Rudolf Virchow, and he is also here not only for that reason, but also as a member of the board of the Berlin Medicine Society, which is a very prestigious society if you look up who have been the members. Please. Thank you.
Yeah, dear Professor Reinhart, dear Professor Spranger, dear colleagues, on behalf of the Berlin Medical Society and the Institute of Pathology, I warmly welcome you to our lecture hall, Ruins at Charité, a timeless monument where medical history and passion for discovery converge. This lecture hall was once a vibrant classroom where Rudolf Virchow, the father of modern pathology, brought an extraordinary collection of pathological specimens to life. Virchow gathered thousands of diseased organ specimens to reveal the physical realities of human pathology, teaching his students to see medicine with fresh eyes under his credo, "No day without a specimen." And you can actually see, as our dean already mentioned, a photo of him up there. He's the character standing right in front behind the desk in a faculty meeting. Originally built during the late 19th century, this building housed Virchow's Pathological Museum, founded in 1899. Although this lecture hall was then mostly destroyed by World War II, these ruins still reflect Virchow's pioneering spirit and the last symbol of our journey to understand health and disease. Today, the legacy of this historic site continues at the Institute of Pathology at Charité, also founded by Rudolf Virchow and located right next to this building. Within these monuments, our meeting today turns its focus to an urgent change in medicine. We are here to delve into the critical issues of sepsis and antimicrobial resistance, topics that remain at the forefront of clinical concern. By bridging our historical heritage with the pressing demands of modern healthcare, I hope you will have an insightful conference with discussions on outcomes and innovative approaches to these life-threatening conditions. Thank you very much.
So, just in time, it's my great pleasure now to also invite Roland Göhde in his capacity as CEO of the Virchow Foundation, and we just had an interesting encounter at the Berlin Global Health Collaborative. And Roland, please extend your greetings.
Yeah, dear Mariam, dear Konrad, thank you so much. Esteemed AMR Ambassador, Mr. Bill Pullman, dear Professor Reinhart, dear Professor Spranger, dear Professor Horst, distinguished speakers, ladies and gentlemen. The burden of sepsis is a global one, as you all know, at exorbitant dimension. And the numbers associated are already well underscored in the speeches which you have heard in the upcoming speeches, 48.9 million cases, with more than 40% children younger than 5 years, and 13.7 million deaths, which means every 2 seconds, almost every 2 seconds, one death case. And we must not forget that these overall figures tend to conceal the dramatic individual cases of sepsis survivors, cases that affect their entire lives, their families, relatives and loved ones, their professional activities, and their ability to pursue their talents and favorite activities, which shapes an integral part of each individual's personality and is inextricably linked to mental health. The testimonies we will hear following this opening session will impressively demonstrate this to all of us. And dear panelists of these sessions, we are very, very grateful for your clear, utmost courageous and important voices. 8 years ago, at the 70th World Health Assembly, the WHO resolution improving the prevention, diagnosis and clinical management of sepsis was adopted. Though, since then, only 15 countries have developed national action plans for sepsis and/or evidence-based policies for sepsis. In April 2024, WHO Director General Dr. Tedros addressed the World Sepsis Congress, underlining that nobody should die from sepsis and that sepsis is most preventable, though effective infection prevention and control, earlier diagnosis, and time-sensitive antimicrobial and other therapies. Today's 2 sessions following the panels will rightly set the important focus on innovative prevention as well as novel diagnostic and therapeutic approaches. On September 10th last year, the 2030 Global Agenda for Sepsis was launched in a special event at German Bundestag. This agenda is shaping the first multi-year strategic vision aimed at elevating the significant human, societal, health system and economic burden of sepsis and its sequelae through concerted efforts at all levels. The central core of this agenda is built by 5 strategic pillars, each with overarching goals, specific objectives, priority directions and interventions, while corresponding gaps are being identified and detailed targets, key performance indicators, and means of verification are being clearly elaborated. This utmost comprehensive agenda has been extremely well drafted by the Global Sepsis Alliance. It marks a significant milestone in the fight against sepsis and the most important effective pathway towards achieving SDG 3 with effects on most of the other 16 SDGs. Overall, and this is a major essence, of the agenda. To achieve success in the fight against sepsis, it requires interdisciplinary and multi-sectoral cooperation, leveraging synergies and following a holistic approach under system-based thinking. On behalf of the Virchow Foundation and of the GHA German Health Alliance, comprising 120 member organizations, today I'm again expressing our unwavering support for the 2030 Global Sepsis Agenda, reiterating that we stand closely together with the Global Sepsis Alliance. Furthermore, I hope that also the Berlin Global Health Collective, which you, dear Mr. Bill Pullman, AMR ambassador, have visited just this noon, that this collective may also contribute as centrally located meeting point for global health-related discourse towards building and strengthening much-needed partnerships also and especially in today's discussed area. How the fight against AMR and sepsis must be shaped is nothing less than a decisive blueprint for achieving the health-related SDGs. And we need to make this fight the next global health success story. I wish all of us a highly interesting symposium and the much required success in deriving the right measures and in jointly shaping concrete, sustainable action. Thank you very much for your very kind attention.
Thank you, Roland, Dean Spranger, Dr. Horst, esteemed colleagues and delegates. It's a pleasure and honor to have you with us for this symposium that was arranged and planned in a very kind of limited time frame. It was an unexpected surprise opportunity for us to host the renowned actor and filmmaker whom we knew as the star from the different beloved movies, but whom we have started to respect and love even more after having the opportunity of meeting him in Vatican and making his understanding about the connection of AMR and sepsis so easy. What Bill Pullman understood literally in 1.5 hours, we're trying to bring to the attention of health policymakers and different global health stakeholders. And we're extremely grateful, Bill, that you are with us today, that you became not only the AMR ambassador, but the voice for truly millions of children, women and men affected by this medical emergency. It's an immense honor. And without much ado, please join us for your keynote, and then we will continue.
I wonder if it works if I don't have this on. Can I just, because I'm hearing my own voice and suddenly I'm picturing thousands of people out there. No, you have to keep it short, otherwise they won't hear. Oh, can I put it right here? Thank you. That's fine. I'm a theater actor as well, so I like the ability to think that I can hold a room this size, but I know you're electronically going for it. And I have to give a speech, which I decided to have a little script along with me, but I want to say that I really have appreciated the opportunity to come to Berlin, the filmmakers, and I have been looking forward to coming here for a lot of reasons. But I'm practicing my speech, so you're kind of going to have to bear with me. And soon I'll be off script with it, but I just wrote it this morning, so I need a little help, a little practice. But I think AMR and sepsis are, of course, among some of the most gravest health crises of our time, and it threatens to undo a century of progress. And possibly push humanity into a pre-antibiotic era where once treatable infections become untreatable. And despite these implications, the scope of the crisis, it's kind of difficult to articulate for me. And I think the connections between sepsis and AMR is something that I'm learning a lot about here. And it's all of it is, there's misinformation, there's public distrust, there's anti-science rhetoric. We know that has increased quite a bit even just recently in the States. But our documentary seeks to cut through the fog, and it's tackling not just, we hope that we can tackle not just AMR and sepsis, the crisis itself, but also a kind of broader challenge that we feel we can do, which to effectively communicate complex scientific ideas to an increasingly skeptical and polarized world. It feels like that larger mission is important now more than ever. You know, in the States, since January 20th, the crazy has been ratcheted up, you know, into a whole new level. So we're going to have to get this movie out and help level that out a little bit. But you want to know how I got to be part of this whole thing? My clothes. No, my hair. No, I'm suddenly realizing that I have had all this life not paying attention to my clothes or my hair. But, you know, when you're in a documentary, nobody's paying attention to your clothes or your hair. So you better watch out. And so I did comb my hair today, which was better than yesterday where I didn't. But I, you know, and I also, I'm a little amazed I get to be here. I've never been to Berlin before. I had a couple of invitations with films to do publicity here. But they didn't work out. I had to work or something. I've been to Cologne and I've been to Hanover. But Berlin, man, what amazing ICUs you have, right? And you know I'm also appreciating the Greek restaurant that's across the street from the hotel, because at 11 o'clock when we get done from the agenda that Konrad Reinhart has set out for us, and also Mariam, I've learned this is a very good Greek restaurant, and I can get in and out of it quick, and we're in bed by 11:30. But I wanted to say that, I forgot that the other aspect of Berlin that I got to know was at Konrad's house last night, where we had a little gathering, and that's a rockin' hot spot. I appreciated that, good time, and it was a very meaningful gathering with a lot of people that were, for us, what yesterday was the first time where, as storytellers, we began to interface importantly with victims of sepsis. And we've been dealing with a lot of policy and storytelling setup and everything, and we started last October in Montana and Seattle, and then we went to Denmark, but dealing with a lot with policy and whatnot. But we were really, because of their careful work and their relationships with people willing to talk about their stories who are heavily compromised. And we went into the ICU and saw a guy, Robert, or sometimes called Ronnie, and that was emotional, you know, to see somebody whose life has been compromised to such an extent, and to feel the compassion of the people that are taking care of him. I did ask Claudia at one point, the leader there, we were talking about how people who have been impacted by sepsis have a challenge with depression. And I said, yeah, I can understand how they would be depressed, and I would also understand how caregivers can get depressed. She didn't blink. She went, Yeah, but we know how to handle it, and we've been experienced with not a second of indulging any kind of that kind of thing, though I think in her eyes I could see she was glad I recognized it, because it's got to be a difficult journey. And I really was impressed by all the people that can keep their sense of hope and the vitalness of preserving human life and improving the quality of human life. And I had never seen that before, so I thank you very much. You know, one of the things that, how it all started was that we went to Denmark to talk to people there who are involved with European concerns, and also Novo Nordisk, which is an important funder there for things. And then we heard about a symposium at the Vatican. And I'd never been at the Vatican before, and I know I didn't meet the Pope, which everyone always asks, you know. But I told the story last night at your house, but I got to tell it again, Konrad, because it was important to me that I was sitting next to somebody that was a very, I would say, an active listener. I could tell he was engaged with all the speaking that was going on, very complicated, people drilling down on their particular, you know, touching the elephant at their part and describing it. And then all of a sudden there was the guy next to me speaking, and it was Konrad. And he can be a force of nature. And I think I was particularly surprised. I had never heard sepsis talked about with AMR. And I have been working not just since last fall with this operation, but I started to reveal my failure part of this journey about 6 years ago. My brother in Montana is an infectious disease doctor in Butte, Montana. And we've had a ranch together for 35 years. And when we get together, we talk about cows and irrigation systems and fences. And we don't talk about what we do during the rest of our lives. You know, there's more interesting and more important to keep the ranch going. But he said, I got to ask you a favor, which I knew was, he's a you know, type A. So he doesn't like to be vulnerable, and he doesn't like to, you know, ask favors, because it means that somebody's going to expect something of him. And but he said, I have a friend who's a microbiologist at the University of Washington, and he's working on a surveillance system for superbugs. He wants to have a way to publicize his activity. And I said, now why should I do that? And I said, what's it mean to you? And he got quiet. And he said, I have been having more and more a recurring fear that happens sometimes in my half-waking state before I wake up, that I'm going to be taking care of somebody who is, he said, fever, sweat, and fear. And I can relieve them of that. But in my half-waking dream anxiety, I sense that I'm not going to have those available to me. So yeah, I am interested in if you could help him. So I went and did it, and I started setting up a development deal with PBS, which is you know, Americans' public broadcasting system, and we worked for 4 years on it. Bright people, 2 microbiologists from the Milken Institute at George Washington University, and when push came to shove, we couldn't convince anybody to give us money. And some of it was that we had a bad title, germs. You know, nobody wants to deal. We just went through COVID. Now we have to deal with germs. We have to pay for it. But I think more importantly, we just didn't quite figure it out. And then by just pure coincidence, I know somebody from my hometown who knew a financier who's had some interface with a documentary film crew. called Creative Chaos. And we sent them what we had so far and said, would you be interested? And they came back and said, we got some thinking done about it, and we've got 5 pages or 6 pages of how we think you could make a movie. But number one, you'd have to agree to be a spokesperson. I almost said, well, fuck that, let's get out of here. So I didn't really want to be on that, but more and more I'm realizing that perhaps and I don't think celebrity endorsements naturally work, and sometimes in the States it can be negative brought to it, but when it works, it works to be important to recognize somebody, and then you can trust them, and hopefully we'll get to that place. I forgot, I'm reading my speech. I totally forgot that actually. I think that yeah, because I also have a little imposter syndrome. Most of my family has been in medicine. My grandfather was a doctor, my father was a doctor, my brother's a doctor, my nephew and nieces are doctors. I have brothers and sisters that are nurse practitioners. You know, they've been hit by the virus of empathy, right? They're all empaths. And I somewhat always felt like I had trouble with 5-syllable words, so I had to be cut out of the science world. But I think, and let's see here, that's right, I do remember my first, one of my first paying gigs was to be a day player, one day only, a role as a doctor on Cagney and Lacey, old TV series. But I had to say some very serious science stuff to Cagney, but I had managed to have a little bit of a superstition about shoes, and I actually have, I'll confide it here because I don't know if it'll get repeated, but we don't want this part of public matter, but I do have a interest in the character that comes with shoes that have been worn. And I have a pair of my father's shoes that he wore when he made rounds in the hospital. And I remember seeing them as a child. And so I wore them on Cagney and Lacey, and it helped me with the 5-syllable words. So that's the closest I've come to the being somewhat useful to the medical world. But I hope that we can make a visually rich movie, and a movie that is emotionally powerful. And, you know, maybe we can help reframe the AMR and sepsis, and it's more than a medical crisis, and it's a lens to examine, I think, humanity's relationship with science and with truth and with collective responsibility. So we have a high bar, and we're going to have intimate conversations with patients and caregivers and storytellers and politicians, and maybe we will be able to get to a clear call to action, and we'll discover in the next year whether that's about education or personal responsibility, and also if we can possibly empower audiences to fight against AMR and sepsis and inspire and maybe encourage some collective action. That's it. Thank you very much. Yeah.
I believe that the venue of today's meeting is very symbolic. We We are in the Museum of Medical History in Berlin. And I also believe that, Bill, with your joining the Sepsis and AMR community, we can make a history in terms of taking the awareness raising, the outreach to policymakers, general public, media, and decision makers, how AMR and sepsis are closely linked and how we have to position sepsis higher in the global health agenda. So thank you so much. It means truly a lot for the amazing people who have gone through their personal life experiences, and we will have panels after the introductory presentations where, you know, it cannot leave anyone untouched by those stories. But even more, the strengths and the bravery and the anger is for making a difference. That is what has driven the real changes in many of the countries, municipalities, cities, and their neighborhoods. So I'm sure after today, we will have a new beginning, and hope we continue our friendship, and we will even grow the collaboration.
I have to quickly change the microphone. They don't see us right now.
Okay. So it's the time for my presentation. I will try not to be too long, but I would like to give you some of the highlights of the 2030 global roadmap on sepsis and how we can make sepsis the next success story. And I would even name this presentation, How Can We? Marvin, I think? Okay. So how can we continue to live in the world where almost 50 million children, women and men are affected by sepsis every year, and we don't speak about sepsis in every single political and global health forum? And those are the numbers. 48.9 million affected every year, more than 30 million deaths annually, 1 in every 5 deaths related to sepsis, 85% of sepsis global burden in low and middle income countries, and children affected the most. 40% of the global sepsis burden is among pediatric population. 20 million under 5 children affected by sepsis, and sepsis takes almost 3 million child lives every year. And how can we discuss AMR? We are extremely grateful and appreciative that AMR became the top theme of discourse in global health politics. It's an extremely important topic. But how can we continue discussing AMR without mentioning sepsis, without acknowledging that the 4.95 million AMR-related deaths every year is only part of the 13.66 million sepsis-related deaths? And how can we overlook sepsis in the global health and development architecture? How can we be serious about attaining sustainable development goals if we don't prioritize sepsis? Look at the health-related sustainable development goals. 20 million children, 5.7 million pregnant women, 15 million people affected by non-communicable diseases and having the secondary complication of sepsis. And similar to COVID-19, every future pandemic will increase the risk of sepsis. How can we achieve SDG 3 for newborn maternal child mortality reduction, or avoiding the unnecessary death and disability from non-communicable diseases and injuries if we don't prioritize sepsis? And beyond the healthcare, sepsis is directly related to poverty and malnutrition. Poor and malnourished children
are at a higher risk of infection, higher risk of sepsis, and higher risk of dying from sepsis. Gender inequality gaps. We spoke today at the Berlin Global Health Collective. Women are affected more than men. 26 million women, 22 million men every year. And even in the Nordic countries with fantastic gender equality index, women are suffering more from sepsis. They are less to be receiving the first hour sepsis bundles timely, and their clinical outcomes are also poor. 120 armed conflicts globally, 362 million people in humanitarian crisis, each of them, both civilians and military and peacekeeping forces, they are all subject to increased sepsis risk. And finally, climate change will complicate 58%, exacerbate the outbreak risks of 58% of the known human pathogens, and each of them will be adding to the risk of sepsis. And we have a fantastic economic case. Again, at the Virchow Foundation today, we spoke about the economic burden of sepsis. 36,000 euro is an average direct medical cost of treating septic patient in the hospital. And that is only 20 to 30% of this overall societal burden. 70 to 80% of sepsis economic burden is related to the loss in productivity, loss in economic productivity, since 1 year after the sepsis episode, 47 to 49%, almost half of people going through sepsis are firstly unemployed. And that's a huge productivity and the societal cost, not to mention the individual post-sepsis process, extremely challenging processes that the patients and their families are going through. And yet we have fantastic cases from Australia, British Columbia, Canada, United States, New York, that every dollar invested in sepsis has brought six-fold return on investment in Australia, only by educating nurses, frontline workers, asking the question, could it be sepsis? And that's how they halved the mortality in hospital and plus had six-fold return on investment. And British Columbia, Canada Sepsis Initiative have even better results. Every dollar invested returned $112 in terms of saving lives and costs. New York State, 16,000 lives saved only from one sepsis-focused quality care initiative in 2015 and 2019, and our dear friends in United States have been behind those initiatives. And on the other extreme, Vietnam, for example, one of the low and middle income countries, 47% of septic patients and 56% of families who lost their dear ones to sepsis, they became poor. They went through catastrophic expenditures, impoverishing expenditures. So sepsis made those families poor because the costs were unaffordable. That is why the governments have to integrate sepsis into the universal healthcare coverage. We shall hold governments accountable for sepsis. Unfortunately, despite the historic World Health Assembly sepsis resolution, only 15 countries, most of them high-income countries, only 15 countries have developed national action plans, and more than 80 UN member states have to still take action. And that's why we are extremely grateful to our partners and the stakeholders for helping the Global Sepsis Alliance to consolidate this first multi-year global strategy for sepsis, learning from other global health initiatives, immunization, HIV, hepatitis, and other success stories. We have the ambition, we have the knowledge, and we know how to make sepsis the next success story in global health. But we need partnerships, we need concerted voice, we need joining the forces for reaching and engaging policymakers. We were extremely grateful to our colleagues at the German Bundestag, Virchow Foundation, Sepsis Stiftung, of course, Unite Parliamentarians Network for co-organizing the official launch of the document in the German Bundestag, and we were honored with a special video address from Dr. Tedros, WHO Director General, where he specifically acknowledged the leadership of the Global Sepsis Alliance in the process, and we have been honored by excellent collaboration with WHO. Those are the Regional Sepsis Alliance for Africa, Europe, Asia Pacific, Eastern Mediterranean, Caribbean, and Latin America. More than 70 stakeholders contributed to the document. The document is built on 5 strategic pillars: political leadership and multilateralism, health system readiness for sepsis and its sequelae, whole of society approach reaching media, opinion leaders, and the general public, sepsis research and innovations. We need investments in sepsis science. We need novel diagnostics, therapies, and vaccines to effectively address this medical emergency. And as mentioned, sepsis has to be part of pandemic and emergency preparedness plans. And if we are successful in implementing the 2030 agenda, we can avert 12 million new sepsis cases over the next 5 years and save 2 million lives from sepsis, not to speak about the economic impact that we can bring in terms of the cost reductions. And finally, it's a very long document, but finally I wanted to summarize 5 major points. What we have to convey to decision makers, what should be our key messages? First of all, we have to establish a high-level political platform globally from ministers of health, members of parliaments, and heads of states who will consistently advocate for sepsis at the G7 and G20 summit, at the UN General Assembly annual General Assemblies of the United Nations, the World Health Assembly, Davos Economic Forum, World Health Summit, ministerial summits, and other major forums. We have to make sepsis the mainstream of global health talks. Second, we have to ask governments to develop national action plans for sepsis and to ensure that those plans are synergized with antimicrobial resistance, infection prevention and control, immunization, patient safety, and other national priorities. Number 3, call for integrating sepsis in AMR, pandemic preparedness, emergency and climate mitigation plans. Creating fiscal space. Government should create domestic fiscal space for sepsis, and international development partners have to generate official development assistance through bi- and multilateral funding sources. The global public-private partnership similar to Gavi and the Global Fund, they can create health system strengthening portfolio for supporting sepsis-related interventions. And finally, investing in sepsis science. Novel vaccines, diagnostics, therapies, both antimicrobial and immunomodulatory, and post-sepsis care. And I hope that through our concerted efforts, we can make this document a reality and take the fight to the next level. Thank you. I have multiple roles, sorry. I'm also moderating. And now I have the pleasure to invite the one and only in the sepsis world, Konrad Reinhart, who was behind everything that the Global Sepsis Alliance has achieved. And he will speak about why sepsis, AMR, and pandemics need to become an integral part of every national and global health priorities. Konrad, please.
Thank you, Mariam. I think you have given the answer already. So that's why I will save some of the time that I have prepared, but everybody needs to understand what sepsis is and what makes it different to an uncomplicated infection, which is the fact that the own body's host response destroys the own tissues and organs, and I don't need to underpin the need that sepsis be treated as an emergency. Can you please? So, and everybody needs to understand, and this was set out already in the WHO sepsis resolution, to which we had the honor to contribute and have the Minister Helge Braun and especially also Hermann Gröhe. Also there it was set out that not only bacteria, including the COVID-19 pathogens and yellow fever, etc., is not, and this knowledge present. And almost no political leader conveyed this message during the 3-year pandemic. You have seen these figures, and I don't want to repeat them, just to make sure that sepsis is not only an issue for low and middle income countries, but also, if you look at the incidence, at least in the range of 700 per 100 population, in those countries where we have data from health records. It's much higher than many other. And this number also has been mentioned, and 7.7 million deaths are, according to this data from 2019, the data from 2017 have been demonstrated in the slide before, makes the point by the authors of the Global Burden of Disease report are related to 33 bacterial pathogens. And alone this would make sepsis, according to their criteria, the second number one cause of leading cause of death globally. And it's hard to understand. And what this means, and this picture we owe also to Moshe Nachavi, who was the lead author of the Global Burden of Disease reports. If you look on the percentage of death by sepsis in all causes, according to this most recent study, you will see, if you go from red, that there are countries in the world where more than 50% of all deaths are related to sepsis. How come that this was not on any agenda? And also in high-income countries like Germany and quite a number of others, sepsis may cause between 12.6% and 14.7% of all national deaths. I wonder why. Oh, okay. And as this is as it is, Sir William Osler, who pointed out in 1889, humanity has but 3 great enemies, fever, famine, and war. If you look at these figures, and COVID-19 deaths are sepsis deaths, as are influenza deaths. Look at the deaths of cancer, and you should also know that between 20 and 30% of all cancer deaths are also related to sepsis. What is the problem? And sepsis can affect anybody, being a celebrity or not. And despite the fact sepsis is not known and the knowledge on sepsis is poor, and this is a poll that we did, a representative poll on sepsis knowledge in Germany in 2022. And you see that still 2/3 of people think sepsis occurs only after wound infections. Less than 10% have understood that also viruses like the influenza virus and like the COVID viruses may cause sepsis. And what you also see, the discrepancy between vaccination rates between Germany against pneumococci and influenza compared to US, UK, Australia, where people are more educated, at least until now. So this may dramatically change as we deplorably have to recognize. So it's the right button. So, and I want to let you know that vaccine hesitancy kills. This is data published in the JAMA. And you see they have data in the US on Republican and Democratic voters. And until September 2019 or January 2020, a time where there was not yet a vaccine, the mortality rate between Democratic and Republican voters was not different. And thereafter, the death rates by death rates increased by 43% in the Republican voters. And the conclusion in these papers was differences in the vaccine may have been a factor in the severity of trajectory. So we need, and we will hear more on this issue. Yeah, so preventable. And these are the measures. Vaccination as emergency. And you see by doing this, started in the US, but only interrupted by this, where the crude death rate increased from 800 to 1,000. The death rate from infectious diseases dramatically changed, especially by public health measures like sanitation, better sanitation, chlorination of water, having health, Department of Health, etc., etc., and of course then developments of vaccines, penicillin and other antimicrobials. And so this proves, but what happens in the US has not happened where 85% of mankind lives up to now. As I told you, the crude mortality rate in Africa is still in the range of 800 per 100,000 population. So this tells us on the, and successes have been made also in other countries. This is just the reduction of ICU-treated sepsis patients in Australia, which decreased between 2000 and 2012 from 35% to 18%, without mentioning the word sepsis, just by the introduction of so-called continuous education of healthcare workers and physicians in the early detection of deteriorating patients, in general, acutely deteriorating patients, and to have rapid response systems which hospital-wide can be addressed if a nurse has a suspicion that a patient is not doing well. And these quality measures have reduced the number of cardiac arrests in the hospitals, because if you intervene early and not only until the cardiac arrest has happened, which is the case in most countries, still the survival rate, of course, is much better. Is there a way that you can move this? If so. And you have seen this data, 6-time return investment by quality improvement initiatives in the 10 major hospitals in the state of Victoria, and reduction in mortality rate also. And we have talked about it already. The reason that in some countries like US, UK, and luckily increasingly in Germany, and that's why I want again especially welcome all sepsis survivors and family members who have come here, who are all heroes, because they were not longer willing to accept poor care and poor education by health authorities and failed prioritization of major issues. And we are happy that we have not only Merope Mills with us, like Mrs. Mills, who have lost also her baby unnecessarily from sepsis, and in the consequence there was a great difference. You have heard about Roland Staunton's regulation, which had to reduce sepsis mortality in the state of New York by 14% by mandated sepsis care. And not only in adults, but also in children. There, where this bundle care, the first measures of sepsis treatment were in children considered, hospital mortality in this age group from 0 to 17 years was 7% compared to 13.2% in those where these bundles in this time were not completed. When we looked up how the mortality rate in Germany is in the age group of 0 to 19 years, it's 16.2%. So we have not only twice as high mortality rate in adults, but also in this age group. And overall, after the implementation of these RORI rules, these regulations, mortality rate in the New York State decreased over 5 years by 10% absolute. And according to a most recent report by the Agency of Health Research and Quality Improvement in the US, they have 2.5 million cases per sepsis in a year. And what they also have documented that there with COVID, there was an increase, COVID-related sepsis by 0.5 million. And so the mortality rate here is in the range with 13.7% in non-COVID sepsis cases and 60.5% there. This enormous burden of sepsis resulted in the US in an initiative under the leadership of Senator Chuck Schumer, who know this child, to have in December in the White House or around the White House a historic first ever sepsis event. And it's about a bill that even more and better ensures sepsis care in the US, and hopefully this is not the measures. And what you can see, and my explanation why mortality rate in the US has gone down over the last years is due to the fact that CDC made sepsis a priority since 7 or 8 years ago. And this is a post only 3 or 4 months ago, who very nicely explained and said any can get an infection, and almost any infection can lead to sepsis. 1 in 3 people who dies in a hospital had sepsis. And there are links, and you can look it up. And this information of lay people enormously differs to the information by governments and health authorities in many other countries. And they have 1.7 million adults and 350,000 deaths. Can you move forward, please? The same in UK, where Jeremy Hunt has made sepsis a priority. And with the result that also there, the number of patients who got their antimicrobials in the first hours increased from 40 to 30% to 70 to 80%. And this went along also with a significant reduction in mortality. Unfortunately, in Germany, we failed. We were able to garner 70 hospitals for a so-called Germany Quality Improvement Initiatives. And between 2014 and 2018, mortality rate remained in the range of 40%. No change at all, which indicates that idealists' voluntary efforts are not effective. And we need to get the priorities right. The priority in US, so they know the facts. AMR deaths, 35,000. Sepsis deaths, 50,000. AIDS deaths, 15.8 deaths. So, and still, in Germany, since 15 years, we have a so-called Germany antimicrobial resistance strategy. And along this strategy, this contains 80 measures in the action plan against AMR. Only one of these 80 measures is dedicated to sepsis. And we have been told, when we asked for a national sepsis plan in Germany, that they will integrate sepsis in the TART initiative. I don't want to comment this in more detail. So, and this is one of the reasons that our mortality rate is almost twice as high. And we only can ask the incoming new German government and they must finally meet our demand to combine infection prevention with the fight against sepsis, antimicrobial resistance, and pandemic preparedness and prevention, and make part of a cohesive national sepsis measurement strategy. Was the first one who brought sepsis in the G7 agenda, and rightly asking what we are rightly through, but it must happen internationally, as said. And with this, I am the end, and thank you for your kind attention. Support our vision: 0 preventable deaths from sepsis. Thank you so much.
Thank you, Konrad. Let me just add that when we ask for the national action plans for sepsis, we are often told that they cannot be separate national action plans for sepsis because there are so many global health priorities. But we have 180 national action plans for AMR around the world, and only 15 countries have it. And as the former health minister, I totally agree that we don't need separate national action plans on everything. But we have to have core elements of sepsis management in the national health sector strategies. I think now we are ready to move to the second presentation, and it's an immense honor for me to introduce you Professor Stefan Kaufmann, the founding director of Max Planck Institute for Infectious Biology in Berlin, and our dear and esteemed friend and colleague. We had a number of joint initiatives, and Stefan, thank you so much for being an amazing partner to the Global Sepsis Alliance and Sepsis Stiftung. Please.
Hello, and thank you so much, and thanks everybody for having me here. And I have to say, yesterday evening when I told my wife I'm talking here, and then I mentioned someone like Bill Pullman, and then I said, I don't know him, but he seems to be famous, and then she, oh gosh! So thank you for being here, and also for doing this great work on such an important issue. Let me start by telling you very, very briefly why I came into the kind of the question overcoming silos. Yeah, it works. Actually, I'm a basic immunologist, but then suddenly I became interested in vaccinology, developed vaccines. I was relatively successful in inventing and developing a new vaccine. But then I also was asked to write or participate in a whole book series. And I wrote it. I wrote about plagues, pandemics to come, emerging pandemics, talked about sepsis, not as much as AMR at that time, but I was aware of it. And then I realized really you have to overcome silos between the different disciplines, but also between basic research, like a Max Planck researcher is supposed to do, and the applied areas. And that's how why I'm so happy to be here and feel so honored also. Now, that book appeared, I think, 2008 in German and also in English later in translation. And a couple of years later, a very famous booklet or a series of 6 publications came out by Jim O'Neill, an economist, and many of you probably know it. He talked about data on AMR, and this was a shocking, really wake-up call, a shocking event. The prediction was AMR will be the major killer in 2050. And the data were on the upper level, one has to say, the prediction data of the O'Neill report, but in principle they were true. And it took a couple of years, namely last year, that also the United Nations took over that in a high-level meeting. They had that for AIDS, tuberculosis, and also for AMR. And these now are the data which I think are very trustable, and you obviously know them, that there are about 4 to 5 million cases of deaths associated with AMR and 1.1 million deaths really attributed to antimicrobial resistance. And then in Nature appeared this one very nice slide. The good news is that infants AMR is declining until 2050, but for the elderly like me, it's increasing rapidly. And even this report then comes up to the 40 million people who will die of antimicrobial resistant bugs if we go on like this. And obviously the situation is even worse. The perfect storm is there, and you know much more about that than me, and that is sepsis, which is so much worse and which is in the order which was discussed so in the previous talks already very clearly. So I don't want to go much into it, but just bring in the link again between AMR and sepsis, because so many are really related to. Now, vaccines actually contribute already to AMR and sepsis control. And the question I want to raise now is, how could we get more out of it? And now I change a little bit from the bad news to the good news, hopefully. This little prick actually can make a difference. And let me start with a hidden bonus that some people always forget or often forget in the context of vaccines. Vaccines not only protect you, they also protect against AMR, and they help to reduce the emergence of AMR. If I'm not diseased of an AMR bug, I cannot infect others. And second, not a single pathogen ever developed resistance against the vaccine, actually. There are some things like other coming up, but that's not resistance in a classic sense. In COVID, you just had to change the sequence and the same vaccine works. AMR is different. The same drug, you can change it, but it won't work again. Unfortunately, the importance of vaccines is not accepted everywhere. And I just bring up a slide which actually the former president, and now president again, Trump, has brought up. You know, we all go on the roads, and we know there is a risk of accident. I promise to you, the risk of having a car accident or a street accident is much higher than having an adverse event of a vaccine. It's in the order of 99.997% to be safe. And there is a little bit left, and even that often is not the causative reason. So this anti-vaxxer logic is more or less see no evidence, hear no evidence, speak no evidence, and I think we better go back to facts now. You can have all the slides if you want. There was a report in, I don't know, the medical people, obviously, the medical doctors here know, there is a morbidity mortality weekly report brought out by CDC, and that looked at vaccination success over the last 30 years in the United States, and they could clearly say we vaccinated 117 million children, and 500 or more lifetime cases of illness were prevented, and to make it short, more than 1 million deaths were prevented. I'm not going into the economic benefits, but it's clear this is a very nice return of investment. Now I have a sad message, actually. The MMR has been signed recently, so the CDC paper, which tells us every day or every week, but to be precise, what's going on in the infectious agenda, has been closed down last week or a couple of weeks ago by the new government of the United States. That's really a sad news, actually. The other point I want to mention is vaccines in low-income countries. There is a program called Expanded Program for Immunization, strongly supported also from the US until recently, I fear. And that showed that over the 50 years when it was active, more than 150 million deaths had been prevented by these vaccines, mostly in infants and small children, young children, over the low-income countries, speak, in other words, the global South, Africa, Southeast Asia. And as we also know, that vaccines, there is a good return of investment. For some 3 million deaths saved, $1 spent has a return of some 40, 50. These are all vague data, but there is a return of investment which some companies would be happy to have, actually. And there is another 1.6 million people which in the European region, which includes all of Europe, including the eastern parts, including Russia, 1.6 million lives had been saved through COVID vaccines over the terrible pandemic between 2019 and 25, more or less, of 23 as a pandemic, more or less. So that's enormous, isn't it? So how can vaccines provide solutions to AMR and sepsis? Let's have a very brief look, and I'm not going into details, major offenders, in my opinion, at least on the bacterial side. What you see is all of those, how many sepsis cases they are approximately responsible for. What you see in dark red, like MRSA, MDR, CRKP, I'm not going into details, we can discuss that later. These are the bugs that are bad bugs. These are the super bugs which have a lot of resistance, and therefore we see clearly overlap between AMR and sepsis. And there is also something in red, pneumococci and meningococci, Neisseria meningitis, Streptococcus pneumonia. These are the two where we have vaccines for. And therefore, vaccines already save lives in the case of sepsis and AMR, but unfortunately, this is not fully exploited, actually, and fully harnessed. Now, can we make vaccines for all these other pathogens that are involved in sepsis? The answer is that's not easy. It's not easy, but many, many ways would be possible. So there is a plethora of pathogens, very different, like humans and some animal species or so. That's the same here. So there is many, many differences, and therefore also the host immunity, that's the basis of vaccines, obviously must be different. They must be tailored to this bug, to that bug, or to that bug. So there is not an easy type. We need different vaccine types, and I'm not going into that. Happy to discuss it later, which major vaccine types would be good. to exploit. But yet, this is clear, research and development for vaccines is complex, but it is not impossible. With our new knowledge, it is indeed possible if there is a strong will, and that is so important what you're doing here with sepsis. There is a strong will, then we hopefully will succeed also to get the vaccines that can be done in the future. And the WHO has recently done a lot of studies on the role of vaccines in preventing antimicrobial resistance and therefore also sepsis. I'm not going into details. This is just a picture showing which are the number 10 of the pathogens that can be approached with vaccines most likely. Let me very briefly go through it here. On top is still Streptococcus pneumonia, pneumococcal. We have a vaccine already. So here we are not in the research and development area. Here we're in the area of doing what we can do and what we should do. So then the next one actually on my list is tuberculosis. And as I learned from the sepsis paper, really in sub-Saharan Africa, tuberculosis is a major issue and the major cause of sepsis, notably in HIV, in people living with HIV. And I'm very, if I may, so proud to say that there is a vaccine in late clinical studies, and that's the one which we developed here at the Max Planck Institute, and the data will be out this year, so we will know it soon. Then there are some pathogens like Staph aureus where we are in advanced development for vaccines, and then we are in a less well advanced stage of development like Pseudomonas aeruginosa, and altogether this is about 4 million deaths that could be prevented by vaccines you make per year. And let me show a little bit how that would look like if we just exploited what we have already, notably pneumococci. Then the existing vaccines could save 100,000 deaths or so, and could also 9 million dailies, and probably you are aware what a daily is, that is disability adjusted years, that is years, 9 million years of living in bad conditions, vulnerable years, more or less, or yeah. And it would also reduce, I want to point that out again, enormously by 140 million doses annually, the use of antibacterials or of drugs, antibiotics, antimicrobials, and that obviously would have a direct influence also on the reduction of resistance, on the emergence of resistance. Now the next would be the vaccines that are in late-stage clinical trials, like the tuberculosis vaccine, if it is successful, where we would have another, very briefly, 100,000, 35,000 deaths avoided, 5 million dailies, disability years avoided, and another nearly 2 billion doses annually, and again, emergence of resistance would be reduced dramatically. And finally, the last slide in this is that some 400 deaths would be prevented if we would have those which are in early stage development ready for deployment and for use in the world. Let me briefly come to an end here, and this is now a little bit more the researcher, namely from known known to unknown unknown. You may know that sentence. We even don't know what we don't know, from Rumsfeld actually in the US. And actually there's a truth in it. So known is, for example, in our case, we know AMR sepsis is a major threat, and we know in principle vaccines can work because we have already vaccines like pneumococcal vaccines. So that's a known. Use that also for other pathogens which are similar to this pathogen, and come to the known unknown. That is, we know those work, and we don't know exactly whether for which ones they work, but we know the similarities between. So I would say that Klebsiella pneumoniae, another pathogen of this type, which could work. More difficult, clearly, is the unknown known, and the word disruptive has become a little bit of an issue because the current US government uses that word, in my opinion, too often. That's a positive in disruptive research means something you wouldn't expect and something new. And here we would go into novel vaccine types, totally different types as the pneumonia vaccines, and go on for that, because this is an unknown approach, but we know the pathogens and the strategies. And finally, unknown, really, that would be the breakthrough, that we have vaccines, or better say host-directed therapies, which are based on our knowledge in immunity, but would also be given in not only preventive, but also in therapeutic approaches, because it may be difficult to vaccinate everybody just to prevent sepsis, but go into therapies, and that is the unknown, where we need the breakthroughs, but that's possible in my opinion. To make it clear, vaccines alone will not solve the whole issue, but they can significantly contribute to the solution, and back to this, a little brick can do a lot. Thank you.
Stefan, thank you so much. Brilliant presentation as always. And we really wish to move to the unknown breakthroughs for sepsis. And yesterday we were speaking about the peace and the ongoing conflict. So the best peace solution is prevention of conflicts, right? And so the best solution for us is the prevention of the sepsis cases. And indeed, we need again and again investment in science, in novel solutions, artificial intelligence, both for early detection, diagnostics, and data generation and evidence generation, of course, therapies, and post-sepsis care commodities. Due to the fact that we're slightly behind the schedule, let me kindly ask you that we skip the discussion part now. We can keep the discussion to the later in the afternoon. And let me hand over the moderation to Ilona, the CEO of the Sepsis Stiftung, and we start, I believe, the most interesting and important panel of today. Thank you.
Thank you very much, Mariam. Hello, everybody. My name is Ilona Köster-Steinebach. I'm the interim CEO of the Sepsis Stiftung. In my career, I have had several touching points with sepsis. I was a patient representative at the Federal Joint Committee, which is a very influential body in Germany. And there I met Konrad, and together with a fellow patient representative, we put on a proposal for a quality assurance program for sepsis. And in fact, this will be in use. It will be mandatory from next year, I think, in all German hospitals. But in my as a patient representative, I very much learned how important the experiences of patients are. And that's why we have 6 persons here who are sharing their heartbreaking stories with sepsis, with life after sepsis. And as there is so little time, I will just have you all come up here. That's Mr. Youssef Kdami, father of a 2-year-old son. Who survived sepsis, yes, thank you, who survived sepsis but is now a quadruple amputee. And we will hear his story soon. We will also have Simon Seyfarth. He also had sepsis as a child and is now a triple master in Paralympics. And he was at the Paralympics, I think. Last time we were due to meet. Then we have Uwe Wiermann. He's also a sepsis survivor and amputee, the regional director for the for a regional amputee association. Thank you very much for joining us. Then many people. We have Mrs. Ilse Malfait. I haven't seen her here. Oh, she's online. Hello, Mrs. Malfait. She lost 2 legs because of a delayed sepsis diagnosis, and became a driving force for major politics improvement in Belgium. So we are really eager to hear about them. And last, but not last, two more people. We have Mariah McKimbrough here. She is the art director of the sepsis. She's the art director of the Sepsis Foundation, and she had to give up her career as a musical actor because of sepsis. And this time, last but not least, we have Arne Trumann, who normally plays piano. Yesterday evening at Konrad's place, he played piano very beautifully. He lost several fingers to sepsis, and he will tell about his experiences too. But first, I want to give the stage to Mr. Kdami and the story of his son, which happened most recently. Please, go ahead.
Hallo? Geht?
Yeah.
Okay, good. So, hello everybody. First of all, my English is not the best, but I give my best. Yeah. My name is Youssef Kdami. My son had last year sepsis. So with 2 years, he was 2 years old, and he lost both lower legs and all his fingers. And yes, we was 9 months in the hospital. And I bring you something with me. This is his new leg. Yes, it's a Paw Patrol leg. You want a Paw Patrol leg? Yes, and yes, that you can imagine how it feels for parents to have a healthy son, and this healthy son lost his feet. It was very painful for us as parents. And yes, so when I hear something about sepsis, I think about this in this time. Before he was ill, I never hear sepsis before. The biggest problem, I think that's the biggest problem. A lot of people, when they heard about sepsis, they don't think about that. They're thinking it's a fuel, yeah, grippe, flu, sorry, flu. Yes. It was a very painful time for my son too. Yeah, it's not easy when you lost your feet. One day before the sepsis came, the boy was fine. He ran around to the apartment and played. The next day, he was ill like a normal flu, nothing special. But at the night, he had blue lips and blue stains in his leg. I spoke to him, but he didn't answer. He was like in another world. I never see this before. Then we ran to the hospital, and they say to us that our son had a sepsis. The biggest problem was that I don't know what is a sepsis. That's the reason why I'm here today, to help people to understand what is a sepsis. Thank you.
Simon, you were also very young when you had sepsis. Please tell us.
Hi, my name is Simon. I am the sports of the Sepsis Foundation. I'm standing here today because I survived a bad sepsis, the meningitis. As a baby, I was 50 months old. My life changed with the sepsis, and I can and I decided to share my story to help protect others from sepsis. When my sepsis had been recognized early, I've received our antibiotics in time, and my life might have turned out different. I'm fighting to raise awareness about sepsis. Today, athletic despite all the challenges, and I use my voice to indicate people. Sepsis can affect anyone, and too often it's decided too late. I want to make sure that no one has to go through this just because they didn't know the signs or didn't get the right treatment in time. Sepsis is a medical emergency. It needs more attention, and we all can help save lives.
Uwe, your story, please.
Yeah, hello. My name is Uwe Wiermann, and first of all, I would like to apologize for my bad English, but I have a very beautiful German accent. When I turned 60, I wanted to test my prostate cancer because my father was diagnosed with it in that age. I went to a urologist, and he wanted to perform a prostate biopsy because my test results seemed concerning to him. However, the same value is also relevant for lung health, and I have chronic bronchitis. Since I didn't know what to expect, I agreed to produce rather naively. The next day, I got fever and chills, and my wife took me to the next hospital in Troisdorf. It is a small hospital. The admitting doctor was the first who and recommended that I be admitted. I follow his advice. Upon arriving at the ward, the first thing I heard was that there was a service staff shortage and that they wouldn't be able to take proper care of me. I can't remember whether I was given antibiotics or if any examination were conducted. I only think I recall it was when I report a high fever to a nurse. She handed me an ice pick. That's all, an ice pack. That night I collapsed and had to be refused. I woke up from coma days later, 2018, in the University Hospital of during the awakening fast dreams. Today, gathered around my bed, and the first thing I said, life is beautiful, and that's true. I was still heavily sedated, which made me re-entry into life easily. I often experienced strong hallucinations. After a few days in the intermedically intensive care, I was brought before a panel of doctors who looked at me very seriously expressions. They explained to me that my legs and my hand would decay and would eventually have to be amputated. I didn't believe any word they say. But it was true. My legs keep turning darker, and so did my arms. It was not a pleasant sight. I was sent from the University Hospital to my small hospital in Troisdorf to decay, as it felt. I lay there for another 2 months before returning to the university for the amputations. This not pleasant sight, but 5 or 10 years ago, everyone with these conditions would have died, says Professor B, before the operation. My inner blood circle has been stranged, but as a result, the other extremities were no longer supplied with blood and began to die. The amputation of both lower legs went smoothly, but was still extremely painful. After the operation, I screamed the room down. It, in a sense, what a human being can endure, because the anesthesia didn't work. I was able to drift into and 4 days later, I stopped it because a nurse say you become a distant. Everything is possible. After 2 weeks, I was transferred to NIMPRO. I did my first interim project, and on May 15th, 28, I was able to stand up again for the first time. Taught me how.
Let's turn to Belgium and Mrs. Malfait. She already also had sepsis, and I not only want to share her story, but what she did about it and what happened in Belgium because of her sepsis. Because when I met patients, many of them, like that one thing we want as patients is that in the future things will go better, that no other people have to suffer like that. And that's unfortunately not true at the moment. And therefore, please tell us about where things went a little bit better.
I didn't quite hear well the beginning. Is it up to me to, can I start speaking?
Yes, please
Okay.
do so.
I have a short presentation. My story began with a small lump in my breast, and 4 days after my first chemo, I had severe abdominal pain and I was rushed into surgery. The inhuman pain the day after the operation was normal, the doctor said. Within a week, you will be home. The 7 hospital days foreseen became 487 emotional and sometimes terrible days. I underwent 22 operations, including the amputation of my lower legs and my fingers partially. Once home, I tried to write down my story to process it. Writing became the start of my search around sepsis. I wanted to understand how a disease that I had never heard of could have such devastating consequences. Thanks to my first Congress of the European Sepsis Alliance, my eyes were opened. I heard about early warning scores, which I applied to my medical records. I discovered that 33 hours were lost before I received proper treatment, despite many alarms on the ward, namely extreme pain, fever, breathing problems, fainting, nausea. This knowledge made me sad and angry. Meeting other sepsis survivors triggered a huge drive in me to fight for a national sepsis plan in my country, Belgium. In 2023, we had some major steps. We raised a non-profit patient organization which is named Sepsibel. My book entitled Every Hour Counts was published at the same time when we had a triggering documentary around sepsis. We had contacted investigative journalists. As a result, sepsis was all over the media, and the minister in parliament asked for a scientific report for a sepsis plan. This report was handed over to the minister last year, who promised to turn it into policy. For the simple reason, he said, that we owe this to all the sepsis victims and their families. We are lucky that the same Minister of Health is on board in the new government, but we are aware that we still have to lobby very hard to get all the steps of this plan implemented. Fortunately, our patient organization Sepsibel is growing, so we have more voices to shout out very loudly. Thank you.
I can only congratulate you and the Belgish people for this, because in Germany, the Sepsis Stiftung is asking for a national sepsis plan since 2013, if I'm right. And all we is one measure in more than 80 in a plan for AMR. So let's go on to Mariah McKimbrough, former stage actor. How did you experience sepsis?
Hello. So the last thing I remember was pressing the emergency button. And after my death, I witnessed decomposition. Who are you when there's nothing left? Over 30 years of stage career was cut short. But it wasn't that long-term battle against a serious underlying disease, but the widespread insidious killer sepsis that turned off my spotlight. And that was it, time out. This wasn't just another chapter. This was a totally different level in a game which I wasn't aware of even playing, a game that was additionally skipped from level 2 out of 4 to level 2 out of 4,000. And nothing prepared me to a reality of facing long-term consequences and over 60 surgeries, 17 times sepsis, septic shock, coma, 2 transplantations. A permanent damage that are rarely mentioned. Coming back from the dead, I found my body and soul in a super meltdown. It was only after I had been resuscitated several times that I really could grasp my immortality. Yes, immortality. 17 times, I mean, that's something. My new life is facing the often unbearable scarcity of the challenges and burdens every sepsis survivor are dealing with. Being faced with disability and/or disfigurement doesn't make it any easier. You get to discover loneliness on a whole new level. And everybody, at least in this room, knows the life-threatening, life-changing experience, but just a few of us can relate. Our health conditions often not only lead to exclusion in our social context, but also to personal withdrawal, to our health-related unpredictable abilities. The people in our lives are insecure, and they often cannot help us. And at the same time, we don't want to be a burden. I realized that everything that happened until this moment was the perfect preparation for the most important vision and mission of my life. The journey leading up to my decision was unwanted. The path I decide to take in the future is my own choice. And one thing I developed over the last years is that ultimate sense of urgency. Tomorrow isn't promised. There is only this moment to do so. I think every opportunity, our needs must be used. And so my encounter with the German Sepsis Foundation is a fateful, and after all, I found my new purpose. As the art director, ambassador, project, PR, event manager, I have the incredible opportunity to play my part in the fight against this shadow, this killer. Thank you, Konrad. Thank you, Mariam. And thank you, Bill, for coming here and making it out from this room, from these holy rooms, into the world. The time is now, and I'm convinced that by pulling our energy together, we're truly becoming a team. A strong and special force of health professionals, experienced experts, and lived experts like us survivors. Sepsis is greedy, sepsis is expensive, and often it costs us both money and life. So, dear sepsis, your time of sneaky hiding is over. This is your stage. This is your spotlight. Thank you.
I don't want to say much, but only one thing: 75% of all sepsis survivors have life-changing consequences after their sepsis. Thank you. And also, Arne, share your story with us.
Yeah, for me, it's my name is Arne Trumann. I lead an average life when I suffered a septic shock in 2012 when I was 44 years old, very untypical. And I did sports, I did my work, built a house, had a family, three children. So really nothing special. And nobody could find out why I suddenly suffered a bad condition. Nobody recognized what it could be, and nobody was aware about this. So awareness about sepsis is so dramatically necessary in the in the people. So everybody, not only the people in the country or in the cities, also the health-related people who are on the scene, not known or heard about to face the urgency or the big point to face if we recognize sepsis. So asking the question if something is unclear, could it be sepsis, might be a good way to bring these patients into medical service as soon as possible, because time is one of what I learned the most important thing. If we recognize it is, then it is very easy to heal this situation. And if we don't recognize it very early and start the processes we need in the health process, then we losing time that we can never cover again. So everybody is asked to learn about that, and everybody has to realize that a septic shock is the last thing that somebody will know, because he will never come back from there. So let us do here everything that is necessary to improve awareness for everybody, to improve the knowledge, to improve the medical services, to improve the politicians who are responsible for our health system. So may this event here be one of the sources to arrive in the Ministry of Health in Germany, to start to overcome to the point that the septic plan that we have to process here in Germany is absolutely necessary. And me personally, I don't care how many deaths we have and where the studies that we source these numbers from, how many people are suffering septic shocks or septic situations in Germany, it is simply too much. And every person we can save here by starting these processes in the Germany health system, every victim that is not a victim is a 100% winning situation. So we should go on starting from here to make it a better world.
I think every one of your stories would have deserved hours. And we are so very honored to have you here and share your stories. But unfortunately, I have to cut short the discussion. We are going to a coffee break of about 25 minutes. We will cutting it short to go on with the program. But I just wanted to add one thing. Just in the time we were talking here with those 6 patients, in Germany 6 people died from sepsis. And another 30 people were suffering from sepsis in those 30 minutes. So just let us do something against that. Have a good break. Würdet ihr vielleicht euch wieder irgendwo hinsetzen? Hello everybody. We have to continue. Ja, ja, ja. Bitte. So, wir haben nur 3 Personen hier. Ihr könnt euch also hier hinsetzen. There's only 3 persons here. You can just sit here.
I have an emergency, I have to go.
Yeah, no problem. I will hand over to Mariah, so everything's fine. So please take your seats. I'm very sorry, but we have to stop, to break down the break and to continue. As always, we have much more to say than we have time. So let's go on with the next panel. That's the panel about how sepsis changes people's lives. We have 4 people, 4 family members here. One is on the screen, perhaps not yet, so perhaps 3. It gives us more time. And I would like to introduce to you Mrs. Merope? Merope, sorry. Merope Mills from Great Britain. She's a journalist with The Guardian. Perhaps somebody knows what The Guardian is. And she lost her 13-year-old daughter, Martha, who died of sepsis 3 years ago in a major London teaching hospital after a series of mistakes. And Merope did something very wonderful. She brought sepsis to the media in Great Britain, and she made a change for, I hope, many, many patients. And she will tell us about that. But first, I will introduce the other ladies here. We have Kerstin Martensen, who also lost her son due to an unrecognized sepsis. I'm so very sorry for the both of you. And we have Sylvia Wiermann, who is the wife of Uwe you already met in the first session, so we can see from the other side of the bed what sepsis is, and perhaps we will have Mariam Pfeiffer here on the screen if Technic is working. She also is now with her husband who had sepsis. But we will start with Merope.
Can you hear me, or do I need the...
You have to.
Okay, I have to. So I know I've got 10 minutes and I will try and keep this as quick as possible. You have to cut me off if I go on too long. My daughter Martha, we were on holiday in Wales and we were on a bike ride, very safe thing to do. It was just a flat path, no cars, but it was near a beach and some sand had blown onto the path and her bike slipped and the handlebars went into her abdomen and she was going very slowly, but the way she fell meant that the handlebars pressed against her and she tore her pancreas. So we were flown to a King's College Hospital, which is a major London teaching hospital. It's meant to be one of the best hospitals in the UK, one of the better ones. And we were there for 5 weeks and we were told all the time she was going to get better, she would make a full recovery, no lasting impact. In 20 years of treating for this injury at that hospital, no child had ever died. So I think they took that for granted. I think that was part of it, that they assumed that she would get better, and they never deviated from that idea. She got an infection, and it was treated with antibiotics, and it went away, and we went through that, and that took a few days. And then a week or two later, she got another infection, and this time they couldn't trace the source of the infection, and the antibiotics they gave her didn't do anything, and she just got worse. Every day, something new happened. She was being sick, she had diarrhea, she had the crazy temperature, like unbelievably high temperature. And yeah, every day she just got worse, and we could see it getting worse, and we kept saying to each different doctor that came in, we're very worried about this infection. It doesn't seem like the last time, it seems different. And they said, no, this is what happens. Infections, they come and go. It's fine. And yeah, it just got worse and worse. Eventually she couldn't stand. You know, every time she stood up, she was dizzy. And we could see the weekend approaching, and it was a holiday weekend, and we were worried about that because, you know, if you work in a hospital, you know that things look different on a weekend. Almost half the people aren't there, and you know they said, no, this is just a normal infection. Don't worry, it's just normal. And then she got a rash on the weekend, and I actually did know what sepsis was, and I said to the doctor, and I had to say it in front of Martha, even though she was scared, I had to say, I'm worried this is a sepsis rash. And he said, no, I don't think it's that. I think it's an allergic reaction to an antibiotic, and I just think you're wrong. And he went away, and I didn't see him again after that. And you know, throughout the night, she was drinking crazy amounts of water. Any doctor here will know that is a sort of last-ditch attempt, and it's a really bad sign. Nobody came. And in the morning, she got up, and she just collapsed in my arms, and she had a huge fit. And she was rushed to ICU, but it was far, far too late. You know, she was dead shortly after that. And sorry, I'm so used to talking about this. It doesn't always do this to me, but the hospital, they did their own investigation into everything that went wrong, and they said that she should have been transferred to ICU at least 5 times. At least 5 times they failed to transfer her. So while Martha's story is a story of sepsis, and I know that's what this conference is about, it is to me also a story of not listening, which I think is a really big part of sepsis, because there's a difference between a normal infection and a sepsis infection, and I think it's not easy to always tell the difference to a lot of doctors, and perhaps one of the key differences is how the family are acting. And I have another friend who I met who took her child twice to a A&E, you know, and was sent home and just told it was a normal infection, and her daughter died overnight at home. So I don't think it's uncommon, and a lot of people contact me with very similar stories. So my sort of anger about this and sadness has been a sort of drive to do something, not just to talk about sepsis, but as I say, to talk about not listening and giving patients a bit more power. And because I'm a journalist, I sort of felt there was a value in the media and using the media to tell Martha's story, and I did that. And I also wanted to introduce something called Martha's Rule, which is loosely based on something called Ryan's Rule in Queensland in Australia, where patients or families have the power to escalate if something's going wrong. They can go outside the team and call for a critical care review. In Martha's case, the on-duty doctor actually said that Martha should emphatically not have a critical care review, that it wasn't necessary. So he told people not to come and see her, and the head of intensive care said it was the only time in his career that someone had told him not to come and review a patient. He said he thought it would worry me more. So this puts the power in the hands of the patients, and through making an enormous fuss about it in the media and getting sort of the whole media on side, including the right and the left and across all different political spectrums, I got most media to back it, and then, you know, the politicians started to back it, and then the NHS agreed to trial it, and they asked hospitals to volunteer to do it, and I think everyone was worried that no hospitals would volunteer, but in fact 143 hospitals volunteered to introduce Martha's Rule, and the results of that have been coming through, and they change every month, and they tell me every month. It's been about 4 months now, and I can't quite remember off the top of my head how many calls I've made, but I think it's something like 500. And consistently, 50% of the calls that are made, and some of them, by the way, also come from nurses and more junior members of the medical team who don't usually have the power to make that call. At least 50% lead to a significant intervention, clinical intervention. Might be antibiotics, oxygen, a transfer back to surgery or a tertiary unit, a third unit. Am I going way over? You have to stop me if I go on. And at least, I think, 50 or 60 people have gone to ICU as a result of those calls. The other 50%, I think everyone, doctors, a lot of people who were skeptical said, people will just be calling this all the time, they'll be complaining about food, they'll be complaining about nothing, but they don't, you know, most of those calls are actually about a breakdown in communication, which I think is significant in itself. That's really where we are with it, and we are waiting to see if the government will fund it to nationwide, the whole, because it requires a critical care outreach team to go around, someone to be called, and we really hope to get the results of that soon, and that it will be rolled out nationally, but it depends if the government are going to put their hand in their pocket and fund it. But I'm hopeful.
Thank you very much. I think we definitely keep our fingers crossed that you will get the funding for Martha's. Really a game changer to enable patients and their relatives to raise an alert and to be heard. Kerstin, your time to share your story.
My son, Jan, died last August, just one day before his planned discharge from hospital. Days before that, his condition changed. He felt weak and he couldn't get up anymore. Then he started to get confused. I ran to the doctors and asked for help. They told me that he already was confused the night before. But no one came to look for my son. Nothing happened. On Friday, the doctor came to visit. And I asked him, what's going on? What is happening with my son? And he said that Jan probably has a clinic trauma and he would be better off at home. His body's fine. When the doctor left, my son told me, Mom, I'm gonna die. And I said, no, Jan. You heard the doctor. Your body's fine and you're supposed to be home on Monday. But his limbs were cold and he hardly understood me anymore. At that time, I didn't know the symptoms of sepsis. I just didn't know. On Saturday morning, a nurse found my son in an even worse condition. He had massive lost blood pressure and was not responding anymore. He was immediately admitted to the intensive care. We had to wait out. It took so long until the intensive care doctor came, and he told us that Jan has a severe sepsis and that he probably won't survive the night. And that's what happened. Our son died just one day before he was supposed to come home. We all fell into a deep hole. It was unbearable. It is still unbearable. I started to read everything about sepsis. I wanted to understand what sepsis is and why it killed my son. No doctor, no nurse recognized that he was suffering on sepsis. A few weeks ago, I talked with a clinic director, and he told me honestly that the knowledge about sepsis is lost in the busy hospital days. And I know I'm just a grieving mother, but I just had to do something. And I started the campaign Jan minus 190. 190 is the number of people we could save. We finally had a national sepsis plan in Germany. And every day, right. And in this campaign, the mayor of Jülich, the city Jülich, was the first one who joined it. And Jan's home city is arming itself against sepsis. All schools, many clubs, institutions, care and medical sectors are involved. The Jülich Hospital is planning information events about sepsis. And a sepsis week will take part in our city from the 23rd till the 28th of June. Different associations, institutions, and schools will show their skills on stage. And they will make memorable statements about sepsis. I want the audience to take notice, and I want to reach as much people as possible. That's what I'm planning.
Thank you so very much for testimony. The fact that 190 people can be saved every day, only in Germany, and we don't do anything, and we don't have a Martha's rule here. We don't have a national sepsis plan is something that enrages me too. Because when I was 17, my father died in hospital from a sepsis too. It was also the day before he was due for a discharge. he got worse. We visited him. He didn't want to eat anything. He didn't want to speak with us anymore. He was feeling dizzy. He was feeling terribly sick. He had fever. We asked the nurses to bring a doctor. They told us, no doctor available. No need. We will give him painkillers. And then he got painkillers. He was told to rest. And he did, till it was too late. And what makes me angry every day, what makes me angry every day is that the same story that happened back in 1998 is happening today, and it will happen tomorrow. And nobody, or not too many people, there are people here who try to do something, but it's still the same, and nothing happens, and it will occur again. And that's something, thank you very much for everybody who is here. We have to change. Sorry. Go on.
I have to breathe out. Just a moment. I'm the wife from Uwe. You know them. His story is told. And this sepsis from Uwe makes our life upside down, pulls upside down, because before we went to the hills and we are walking everywhere, and today we are always looking, is it flat or is it high? Because Uwe can walk, but is a bad feet. He don't move, and you can always walk a flat way. It's normal, but we do the best, and we try every day to make a good day, because we know this is life 2.0, what we have both given, because Uwe is alive, and I'm very glad that he is alive, and he's a friendly man, and he's always makes jokes every day, perhaps in the hospital, as his legs and as his fingers go darker and darker. He told stories, little children, from Indiana, with Blackfeet, and today he fights for the sepsis and for the people to get a good life after sepsis. And I think we all here little soldiers against sepsis. Every day we go out and tell about sepsis. What does it mean? I often talk to sepsis patients, and 4 from 5 times they get pneumonia, and this is a reason to have sepsis. Thanks.
We ought to have another person here. She sent us a short video with her story. Then I will put some brief questions, and unfortunately, yeah. Go on with the video.
Sepsis caught us by surprise in a hospital. It was diagnosed far too late. My husband was 52 years old at the time and worked as a tribology expert at Continental in Frankfurt. Our whole life changed from one moment to the next. The battle in the intensive care unit seemed to have no end, and we as a family reached our limits. There was no psychological help or other support from the authorities. No networks, no contacts, no one felt responsible for emergencies. After 21 months, my husband left the last hospital and has been an intensive care patient ever since. 24-hour care in the house, and we are still getting used to this situation. I had to move into my own bedroom because I couldn't get any rest at night. That hurts my heart a lot because I'm glad my husband is at home. Everyday life consists of driving to the office in the morning and being back home in the evening. Trips are hardly possible because my husband has a tracheostomy. He is also quite weak. He has not yet regained his ability to swallow properly, so he has not been able to eat anything since September 2022. But eating is a community, and we cannot manage to go to events or restaurants together because he cannot eat. When we go for walks, we are met with pitying looks, and many often do not know how to deal with us. At work, you are expected to do your job as usual. Nobody cares if you had a bad night or if your husband is not feeling well. That is interesting because many colleagues talk extensively about the aches and pains of babies and children, and this is completely accepted. What have I missed? I missed a care period similar to maternity leave when you come home with a baby. I missed psychological couples counseling in the clinic before being discharged. I did not have a psychologist at my side. It was not until much later in 2024 that I received this help, which helped me incredibly. I am aware that people deal with strokes of fate in different ways, but I have decided to work through the topic of sepsis for myself and network with other sufferers, and that gives me support. If you realize that things are not right, you should try to help change them because we have a responsibility to our families and friends and, above all, to our children and grandchildren.
So, not much time left, but I want to put one question, especially to Kerstin. What message do you have for policymakers?
Minister of Health, Mr. Lauterbach, and I asked them the question, why don't we have a national sepsis plan in Germany? And I wanted to know who prevents it. I got no good answer. Nobody told me anything about that. And then, I'm sorry. I'm okay. I wanted to know why they don't do anything about sepsis. Well, they told me they do already a lot. And then I just thought, well, I can tell it's not enough. We can tell it's not enough what they are doing. Then I finally got an answer for my question from the federal government from the office of the federal government, from Commissioner of, Patients Affairs. They told me that sepsis is a quiet subject, and the politicians can't reach enough of the population with this. And that's the reason it's not a priority for the politicians. And so they don't do much as they should do. And then I think 380 people dying every day, and so many with serious long-term damage. And to bury our own children is not enough. Our son gave his life, and I want them to listen to Jan's call and stop this unbearable situations. Thank you.
Yeah, just to add one heartbreaking fact. 3/4 of the people who survive sepsis have life-changing disabilities, we know that. And in Germany, normally people are entitled for rehabilitation. So that's care after the immediate care. And there is no special program for sepsis in Germany till this moment. So that's one more point to add on the list of the policymakers for the future. Thank you all so very much. We were so deeply honored to have you here and share your stories. Thank you. The best sepsis is one that never occurs. So we should change to prevention for sepsis. And I will hand over the moderation to Mariah McKimbrough. You already know, the art director and much more of the Sepsis Stiftung. And with respect to her past, I will say the stage is yours. Thank you very much. I think I have to. Without. All right.
So now I try to compose myself after listening to this. Our next speaker is a very strong, wonderful person. His name is Michael Sasse. He is from the Pediatric ICU Network, Medical University of Hanover. And he really is a wizard. Michael? The stage is yours now.
So, thank you very much for the invitation. We heard a lot of horrible private stories from deaf children or damaged children and adults, and I think we have to do something. So I want to present the multi-stakeholder project for reduction of maternal and kids sepsis. Here we want to include here in the whole of Germany. And we don't want children like this, as Philip with a meningococcal sepsis. We heard the stories about the patients. We don't want death by sepsis. We don't want organ failure. We don't want amputation. We have here Marlene, pneumococcal sepsis with a destroyed brain. We don't want cerebral injuries by sepsis. We don't want to hold neurological disabilities. We don't want chronic morbidity. So here you can see the high-risk groups for sepsis and sepsis morbidity and mortality are young children, babies, newborns, and infants, and they have the same risk like older people in our society. You can see here and here. We have now current estimates in Germany 500 cases per year and 140,000 deaths. I think that's horrible. And we can reduce the mortality of sepsis. Here, for example, we have the standard here in Germany. We have a mortality rate for children with sepsis with 60.6%. In better organized countries in Europe, we have only a mortality rate like nearby 12%. We have good practice examples, for example, in New York, who reduced the sepsis mortality to 7.5%, and we have the best practice examples all over the world, only 2 or 3 in the world, who reduced the sepsis mortality only to 2%. That's possible. You see here, for example, a campaign in Australia and New Zealand, and we have a decrease of sepsis mortality in adults from 35% to less than 20%. And here you can see the development of the severeness of the sepsis. At the beginning with prevention, you get no sepsis, you have only an infection. But if you wait longer and longer, I think the severity of the sepsis will go up. And here, for example, it's no way back to a life you will ever die. And we know that training of medical staff for early recognition of sepsis and treatment by emergency teams reduce the mortality of sepsis in a very, very high manner, and with decreasing of medical resources like in Germany and the other European countries in the moment, the awareness of the civil society becomes more and more important. Here the treatment of sepsis is very easy, and all the people who get a treatment here in the early phase get normally a complete healing, but in the later phase here, for example, when you are on an intensive care unit, they have a very high mortality and morbidity. So the main focus is that the recognition of a serious ill sepsis child and adults is mostly delayed, and this leads to a too late start of therapy. And that means that time is life. The earlier your treatment starts, the higher is the survival rate. So we have to go for our whole society an increase of awareness of sepsis symptoms. We create now the Kids Mom Sepsis Competence Project, a project for the increasing of sepsis awareness all over the country. We include a lot of expert associations and civil societies that leads to wide base for better treatment of sepsis all over our country. The target groups in Germany are the peripetal people, that means newborn and moms. We have nearby 700,000 births per year in Germany. We have, for example, 26,000 midwives, and we have maternity institutions, 730 all over Germany. And then we have a group of children and the adolescents. We have resident pediatricians, more than 5,000. We have nearby 340 children's hospital who has to teach and educate it in the recognition of a serious ill sepsis child. And we have public departments, health departments all over Germany with 377. And we have a third working group, it's the civil society. We have, for example, children's under 18 years, more than 40 million children in Germany who has to educate it about infection and about hygienical things and prevention of sepsis, for example. We have more than 20 million of parents. We have now in Germany more than 200,000 children who need home care because they had a chronic morbidity. And we have more than 800,000 teachers and nursery teachers, 700,000 who has to be educated about infections and sepsis. So what are now the projects in our whole project, in our campaign? We have to create checklists for early recognition of a sepsis child and serious ill child. We have to create easy, comprehensible giveaways, for example, without a lot of text, more by pictures and pictograms. Like here, it's an example from the Queensland government in Australia. We have to build online platforms for professional and lay persons to educate them about infections. We have to build more networkings up in Germany. That's an example here in my surrounding, in Hanover and the north of Germany. We have now 52 children's hospitals who are in an intensive care and sepsis network with a lot of education and with a 24 hours service for sepsis questions, for example. We have to standardize learning programs for professional rescue teams all over the country, families, children and teachers. We have to build up sepsis competence teams in all children's hospitals in Germany. We have to build a central sepsis consultation service of 24/7 a day. We have this in Hanover since, I think, more than 21 years now, but we are the only single center in Germany who can work with consultation service like this. And we have to need a scientific investigation of our project, of our campaign in the next years. So, in summary, structured and standard reduced mortality and morbidity in sepsis. A large group of stakeholders is necessary to achieve sustainable progress, and the civil society is more and more an elementary factor all over our country. The delay of the recognition of a serious ill sepsis child and the start of therapy has to be reduced, and the prognosis of sepsis in children is so excellent that all the work is acceptable for better the life of our children. Small changes, only small changes, lead to dramatic success in the treatment of sepsis in childhood, and so go for it and go for life. Thank you very much.
Thank you, Michael. I told you, he's the wizard. So, there is another wizard, Miss Irmgard Landgraf, board member, GP of Association Berlin-Brandenburg, and she proves why prevention of sepsis through digitalization and networking is key at the nursery home and everywhere on the planet. Thank you.
Yeah, I'm very pleased to be here today speaking to you on the topic of sepsis prevention in nursing homes. And we, the family doctors, can do a lot, you will see. First of all, I'm sorry, my English is not so good. I hope it is enough. Whoops. Yeah. In the next 10 minutes, I will give you a brief overview, significance of sepsis for public health in Germany and risk groups for severe septic causes of infections. And then I will explain the networked cooperation between nursing staff and physicians, which we do for more than 20 years now, and which can very efficiently prevent septic disease progression through early medication of infections. For elderly and multi-morbid, the following is important in connection with sepsis. Approximately 80% of sepsis cases originate outside of hospitals, for example, in the nursing home. And it is also very important that elderly, multi-morbid and immunocompromised individuals have a high risk of developing and dying from sepsis in the course of an infection. In this view of the demographic developments in our country, we are facing major challenges. You see here in this population pyramids that in the next 23 years, we have more than 30% of people who are older than 65 years. And we know with increasing age, the need for care grows, and so do multi-morbidity. Need for care grows, and so do multi-morbidity, dementia, and frailty. In this case, we doctors, doesn't work, have to prioritize the available complex diagnostic and therapeutic options as well as polypharmacy based on the situation of our patients. And we know we have in the next years, we have an increasing need for nursing home care due to the decreasing care capacity of families. Okay. Here you see in the above it illustrated that in nursing homes they live elderly, often multi-morbid, cognitively and or physically impaired patients who no longer have sufficient everyday competence, and they need extensive nursing support and also require a high level of medical care, and they have to be treated in the nursing home. They can't leave it. Therefore, nursing staff employed in the home and work in shifts round the clock. Doctors providing care in nursing homes in Germany generally work in their practices, which are more or less distant. If residents have health problems, nursing staff must contact the doctor treating them and have to inform them. And that is not easy. The practices cannot usually be reached directly per phone or fax. You know it. The telephone is constantly busy. Messages can be left on answering machine or via fax. And when we, the doctors, call back at the home, we often cannot reach nursing staff either. They cannot take calls during nursing work. If we do reach a nurse, it's not necessarily the one who knows our patient and their current problems. This nurse may not longer be on duty. As a result, we often receive information that have been passed on from one nurse to the other, which leads to misunderstandings, sometimes even loss of information, and deterioration in quality of care. Waiting to the next ward around to exchange necessary information between doctors and nursing staff is not a good solution, as it can endanger the health of the residents. Now, every nursing home has patient files that could be used for information exchange. However, in Germany, many homes still work with paper files. You see this? These handwritten entries are not always easy to read and are often not well organized. Nevertheless, nursing staff have to take their instructions from them and also document their work there. We doctors have only access to these files when we are on site at the home and if the files are presented to us. These files are not suitable to provide exchange of information. If care homes work with digital files, documentation and the exchange of information will be much better, thanks to improved legibility and a clearer overview. And if this nursing home software is network compatible, the intersectoral and interdisciplinary exchange of information can be significantly optimized. This because we can then just on this way communicate asynchronously via the digital files without disturbing each other in our day-to-day work. We can exchange observed symptoms and necessary diagnostic and therapeutic measures promptly and significantly improve the quality of care in a resource-saving way. And we don't need to discuss too much between doctors and nurses. In practice, working in this way is very simple. We, in our nursing home, have several computer workstations for nursing staff in the different home wards. I myself need 2 computers. One I need to log into the practice software and one I need to log in the nursing home software. And then I can communicate digitally between the different systems with the with the nurses. I use the documentation of the nurses to carry out my therapy controlling and also use it to prepare the regular ward rounds. My login in this software requires several passwords, and finally a token number, which changes all 90 seconds. And in the system itself, I have to bring me out as the doctor to identify me as the doctor, and then I can look to the records of all my patients. They are normally here. And on our nursing home, software has communication modules for short informations or for longer, for more exchange of information. And I informed with a green button in front of the name that there is information for me from the staff. When I look this information, I can decide, do I need more diagnostic? Have I to change the therapy? Can I do this online? I can, for example, issue a e-prescription, and I can this send via KIM to the relevant pharmacy. KIM is our data protection compliant communication system in healthcare, and pharmacy can deliver the prescribed medication as quickly as possible. And then I can decide, when shall I see the patient, when shall I visit him, is it necessary to do it immediately or later? In order for us to work successfully in such networked manner, we need, in addition to the technical requirement, qualified, this is the technical requirement, but we need really qualified employees at all levels of care who know each other, who can rely on each other. This means that they must use the digital files reliably on a daily basis and undergo regular training together in order to develop binding standards for collaboration. We make this mandatorily for nursing, for all nursing staff, twice a year. And we address the question, what constitutes an emergency for our elderly multi-morbid nursing home residents, and how can we prevent it? In this training, the nursing staff are also trained to recognize symptoms of an infection at an early stage. That is not easy because infections often take an atypical course in older people. In any case, nurses have to learn that they have to inform us, the family doctors, immediately at the first signs of infection so that we can react diagnostically and therapeutically on the same day and thus prevent septic diseases causes. Of course, we also discussed the warning symptoms of sepsis and that we have to react of them immediately with medical intervention. Robert Koch Institute has this very simply but good understandable symptoms what we give all nurses for their daily work. Working in such a networked multi-professional team has many advantages. As a family doctor, I'm always informed about all my patients' health problems at a very early stage, and I can intervene quickly, even without a home visit. The possibility of online controlling and online monitoring improves treatment and patient safety. We, doctors and nurse staffing, work closely together in our network. We learn from each other, we become increasingly competent, and together we can significantly reduce dramatic diseases and the need for inpatient treatment. This is very important and we are proud of this. For the last 30 years we work in this way. We haven't had a case of sepsis in our nursing home. Our conclusion, none of us want to do without digitally networked collaboration anymore and without this good collaboration. Thank you for interest.
Yeah, we can only say congrats. Wonderful. It's proof it can be done. So we heard the kids, we heard the elderly, and now we're going to hear the one and only Konrad. You want to take over, or is it a discussion?
In terms of time.
Yes, in terms of time.
I think I would take over for the next session.
Right.
But without, I can cuss. So it's unique. So what you have demonstrated is really what we have been saying and what Dr. Tedros have been saying. Sepsis is preventable. It's just a question of dedication, organization, and so forth. On the other hand, I think we need to realize Mariam Jashi has really made a difference by helping us to putting up a global agenda against this fight against sepsis. And we won't get there if we don't get involvement of the policymakers as needed. And it's unbelievable to learn how high-profile policymakers answer questions in this country compared to what we have seen. And you just need to look up the documentation of the Ombudsman in England. He reports annually where they failed despite the dedication of Jeremy Hunt to the fight against sepsis. So this is a culture, and as long as we don't change this culture, we will not be making any progress. Just to say that much at this stage. And likewise, to make progress in cancer, in HIV, in every other major disease, in cardiology, it needed research to improve novel diagnostics, to shorten time, to be effective, personalized medicine, etc., etc. And that's what it's about in our next session, and it's why I call Björn Vollert as Chief Medical Director at Thermo Fisher, who have developed sepsis markers, and which we will hear, I'm sure, will be helpful not only in the terms of using the misuse of antimicrobials, but also in the early diagnosis of sepsis. It's yours. He's not only a brilliant musician, what we learned yesterday, but also a good scientist, and by training a cardiologist.
Thank you very much. First thing is I have not invented and developed the PCT, but one of the first guys who further developed it is sitting here, the speaker next in this thing, and Thermo Fisher incorporated this marker in their brand, just to be fair here. Okay, if I'm too slow, you just have to tell me speed up, because I have a lot of slides. I'm talking about sepsis, low respiratory tract infection, and antibiotic resistance. This is an important subject, as you can read in the title of my lecture already. We have millions of people, and this is very important. This is a presumption of the World Health Organization that there will 10 million extra dead people by resistance of antibiotics, mostly in Africa and Asia, but they have more people as well. Yeah. So it's also a problem in the Western world. And when you say, oh, it's Africa, Asia, maybe it's not relevant for me. Yes, it's relevant for the US, for example, as well, because patients without resistance, they need much less money and treatment than patients who have resistant germs in their blood. Yeah? So it's also a good idea, not in terms of economics, not to have antibiotic resistance. There are a lot of things we can do. We have to prevent. You were talking about it, about awareness, about detection of sepsis. It starts for a surgeon with washing his hands properly. Vaccination is something in there. I'm not talking about this. I'm talking about the early diagnosis and how we can improve the antibiotic treatment, because the less antibiotic we give and the more focus we give the antibiotics, the less resistance we have with antibiotics. Yeah, and now this is a look into the, for the doctor. He has two objectives. He wants to treat the patients with bacterial infections, but he also wants to avoid overusing antibiotics. Yeah? So he always have to select, what should I do? Yeah? And it's here to treat or not to treat. That's the question, like Shakespeare said. And what's behind this? So the doctor also knows there is antibiotic resistance. So he is also afraid of this resistance. And that's why he's often giving antibiotics who are very high potential. But this high potential antibiotics, they are causing antimicrobial resistance. So it's a circulus viciosus. And a very good sentence for me when I started as a medical doctor. I started here at the Charité and I started in intensive care. And I've seen patients with sepsis. I know some faiths similar to what I've heard today. We had dead people by sepsis when a child was lost. It's always totally dramatic. Yeah, still you can cry from this. Yeah? Me too. I was very touched of this. Anyway, medicine makes faults. Yeah, it's in the nature of human beings. Thing is, you have to learn from this fault, yeah, and to do it better. And my first boss, he was also from Bavaria. I know you're from Frankenmoor. He had a rolling R, and he was coming with good sentences. He said, "Young man, first things first." Yeah? First things first means do the right diagnostics. And if you look at the entity of people who might have a sepsis, you see that everybody in the room had a common cold, maybe, yeah? But you do not need antibiotics for this. And you don't have to be so afraid as a doctor, because very few people of them die. It's totally different if you have sepsis. You have to give antibiotics, yeah? So this is in the head of the doctor, and the question is, can we aid this and to give the right people the antibiotics? And not to miss this, yesterday by accident I saw a picture of Konrad with a mustache. I was very surprised. It was in your driving license, I think. And so I put this photo. I was thinking about this slide 1 hour to put it in. But I was young some days ago also, and I had a rock band. And this professor who told me first things first also told me very first things first, your haircut is not acceptable. Okay, so... So to make the story with PCT, I can even show it in 4 slides, the power of PCT. There are some biomarkers in the blood, like TNF-alpha, IL-6, PCT, and often measured C-reactive protein. And here you see when the toxin is coming that the PCT is rising fast and high, and it has a very good half time, because if you measure it every day, you can see good differences between the measurements. Here, for the people who maybe are not so familiar with medicine, it's like to detect, if the test is good, if it detects the right people who are ill as ill and the right people who are not ill as not ill. Yeah? Sensitivity and specificity. So if the curve is running like this, it's the best marker. You can easily see that PCT and in many studies outruled other markers here in the sepsis diagnosis. And also PCT is related to the severeness of sepsis. The more severe the sepsis get normally, the higher is the PCT level. And this last slide shows you what happens if you use PCT when giving antibiotics. So if you give antibiotics and you measure here day by day and the PCT is not falling, the antibiotics is not effective. Yeah? You can then change the therapy, like you see here, and then the PCT should fall if you give the right antibiotic. Yeah? Or if you start from the beginning very, very right, yeah, you see a fall in PCT. That's how you can make with this biomarker guidance of the antibiotic therapy. And I can stop here my lecture even, but since we are in a medical faculty, I always have to prove something and show you proofs and proofs and proofs. The good thing on PCT, these studies before, they are 25 years old, okay? And in the past 25 years, we had so many new trials, randomized controlled trials, blinded trials, meta-analysis, where a lot of patients were pooled, thousands of patients, and that makes the power of the medical results much, much better. And here you have studies in low respiratory tract infections, in adults, in children, same thing for sepsis. And you see, depending on the studies, you can save 16 to 74% of antibiotics here, yeah? And without compromising so that the people do not die more often, yeah, statistically. Yeah, and this is shown here in this study. So the PCT use here is even associated with a lower mortality, a little bit, but it helps if you use PCT and you do not kill the people. So you don't have to be afraid of trusting your PCT result. Yeah? So now a short overview about some important study. First, lower respiratory tract infection. And what you see here are things like asthma, bronchitis, yeah? How many antibiotics you can save if you use PCT, yeah? Because the infections are viral. They are not caused by bacterioids. And if they are not caused by bacterioids, antibiotics are not effective. They are even harmful to these people if you treat them with antibiotics, yeah? So you see this here, and there is no difference in outcome if you use it in this study. This study here was confirmed by other studies. And then when I started medicine learning here, it was always eat the package. Yeah? You got antibiotic, eat the whole package. Yeah? All 20 pills. If you don't eat the 20 pills, something really bad will happen. Yeah? So this changed a lot in the last 2 decades. Yeah? And you can treat patients more individual. Yeah? You can, even if you measure the PCT and you see it's dropping, yeah? You can stop antibiotics. Yeah? And you see here in another work how many antibiotics you can save in different diseases. Yeah? It's days of giving antibiotics. Yeah? And so the overall reduction related to some disease as community-acquired pneumonia are 1/3 up to 50% and more, yeah, in saving antibiotics with using PCT. Yeah? And then the people say, yeah, but maybe then this is harmful to the patients. Yeah? Sorry, how do I get back? Yeah? But it's not, yeah? And here you see a meta-analysis, 6,000 patients in 12 different countries. It's always the same. If you use PCT properly, you can save antibiotics. This is the message here. And now you can say, okay, this is low respiratory tract infection, bronchitis. Okay, you don't need antibiotics, but we are dealing here with critical ill patients. Yeah? They can die if you don't give antibiotics. Which is true. If they have bacterial infection, sepsis, you have to give the right antibiotics. Yeah? But when you are dealing with this in an intensive care unit, you see this in this study. Also here, you have clear signals for concentrations, when to start antibiotics and when to stop antibiotics. And if you do so, you see that you can save 3 days of antibiotics also in the severe septic patients. And then people said like, yeah, but then they maybe die more often. And this study came 6 years later in 2016, the sub-study, and they were not only looking for the consumption of antibiotics and the duration, they also looked for the mortality. And first result is 2 days of antibiotics could be saved if you guide the patients with PCT. And there was a randomized controlled trial, blinded with a standard group and so on and so on. So it was compared to the normal medical standard. But what you also see is that it was more safe in cause of mortality. Less people died with using PCT and with stopping antibiotics more early and with giving the right antibiotics to the right people, yeah, to the right germs. Yeah? So one last study in this block, which is more important today, is when you talk about antimicrobial resistance, you look into the gut and in the intestines, and You can also look in the stool for bad germs. Yeah, bad germs are something like here, Clostridium difficile. They are resistant against antibiotics. You don't want to have them in your body because then you have no more antibiotics to fight them. Or these other ones here, and they were measured in the stool. And what you can see here also, if you treat the patients with the PCT guidance, you have less of these multi-resistant germs in your stool. So it's good to use PCT here. So Konrad gave me a sign, so I skip this. You have less antibiotics and less exposure, and you can even save money with it. Yeah, and the authors think, yeah, it's maybe because the harmfulness of the antibiotics are not so much. 2 minutes, Konrad, please. You say I'm always. I'm showing only old studies. This study was from the UK. The UK is a strange island within Europe. They are kind of Europe and not Europe, and their medical system is very challenging, I would say. Yeah, and they have to make quick decisions and so on. And you see here they tested also PCT. They compared PCT to CRP. They want to look for the durations of antibiotic givenness and the mortality. And here you have the special groups, the cutoffs where they decided to give or not to give antibiotics. And what you see here, you save 1 day. Here also in the UK, I have to say, as a European, yeah, you saved also in the UK antibiotics. And for this, the good message for the doctors is they only have, I mean, it's difficult for doctors. It's 2 values already they have to know. Yeah? One is 0.25 for low respiratory tract infection. The other is 0.5 for more severe diseases. Yeah? And also for the guidance of antibiotics, when to stop it. If they decline for 80% in the next measurement or they fall under the first things, you can stop the antibiotics. There's a lot of evidence about this. This is also in the worldwide guidelines, and this is my kind of my pre-summary from Winston Churchill. So you fail if you do the wrong things again and again. Yeah, you have to learn it again then. Yeah, and you make the same faults. PCT for me is a must in the infectious setting, and it's growing more and more. And there's no clinic in Germany who's not using it in intensive care, but not in the emergency room. That's a problem. Yeah. And it helps to overcome the fear of the doctor, yeah, for prescribing antibiotics. And here's one of my favorite philosophers, yeah, and he said, like, this is also a problem because we are human beings. We make these faults, but we have to learn from these faults, yeah. And we have to do new research. PCT is very, very good, but it can be better maybe. And we are looking for other biomarkers, my company for this biomarker, MR-Pro ADM, for example. And out in the space is now machine learning, AI-driven things. And with this here, I stop. It's the last 3 months ago it came out, because now there is one FDA-cleared algorithm for the sepsis prediction here. Yeah, it came out in the New England Journal of MI here. And you see they developed a sepsis immunoscore to find out if the likelihood of sepsis is low, medium, high, or very high. And for this, they gave the machine a lot of data to learn like artificial intelligence is, and they tested this on real cohorts. Yeah? And after you did it, they see, is our machine good in predicting sepsis and making the sepsis diagnosis. And when you do so, yeah, you can also find out who is the best marker, who has the most power, who is the most powerful marker, yeah, to give me the best probability. Yeah? And guess what it is? Yeah, in the first place here was PCT procalcitonin. Yeah, before the respiratory, you see here the clinical parameters as well. Yeah, respiratory rate, what Konrad telling in his educational programs. Yeah, look for this, look for the blood pressure and other clinical things. But you see how good is PCT, and for me it's no surprise because over 3 decades of massive scientific evidence, we could show that PCT value is very, very good and very, very value and very high. So the doctor should use it. It makes it better. And this, if you want to have my lecture, you can read this at home. But everything that's written here, it's standing here, and this is my summary. Thank you very much.
Very, very good. This is the good news. The bad news is, again, here it took 30 years to get in the New England Journal with this data. I was a very skeptic, I may say, on PCT. And I think I have treated more patients than anybody else on the basis of PCT because I fast was convinced that it's better what we had before. But, as I said, it should not only use in the hospitals and not only on the ICU, but there where the patients go most, which is at GPs. But there's no remuneration. It costs so much money. Why don't we do it? So it's the same thing as long as policymakers don't go with science. We spend useless money and it costs lives. And there's another area in which I spent also almost 30 years of my years, which is life. It's the development of innovative immune modulatory therapies. And I am very biased here because I was in some way connected to these developments, and I asked my good friend and former ICU director in Jena, Niels Riedemann.
Yes, thank you. Thanks, ladies and gentlemen. Thank you so much for the invitation and for this wonderful event bringing together AMR, that important topic, with sepsis. And with that, Bill, big thanks that you are the ambassador, because we need people like you and we need people telling the stories, because this is what's about. Today we're going to enter with this little talk here a bit about what happens if you develop a sepsis. Can you still be saved, right? You need antibiotics, you need treatment early, much better is prevention. So all the efforts that were talked about today is really about listening to the patient who knows his child or himself. And I do something which I very, very rarely do, because I realized when I put the slides together for this talk, this is a bit like sharing with you a big part of my professional life. And so I was thinking, to share with you what bothered me in my life when I became an intensivist and ran a large unit. So when you come to the hospital as a patient, and I've been in hospitals as a patient, you kind of lend an unconditional trust. You don't even know that, but you somehow do. You go in that hospital and you don't doubt that everything is done in there to get you out alive and well. And unfortunately, I came to the conviction that my, and probably also your life, in the hospital is a lot less worth than outside of the hospital. And that's a very sad truth, because it betrays that unconditional trust. And that has to do with the system. It's not that there are bad people working in the hospital. It's not that there are bad doctors or bad administration. It's the system is not centric. And I found one comment today very touching, that the sepsis is a topic of not listening. And so that's a learning I wanted to share. That's why I feel very honored to tell you a little bit about what we did, what happens, like can you treat someone that has developed a sepsis, and is there something, because sepsis' definition is the immune response of the human body to an infection, right? So I will talk a bit about immune response. And since we're a public company and I'm the founder, one of the founders I should say, and the CEO, there's a disclaimer here just for forward-looking statements and other things. And I do have to do a little bit education, and I will stand down there and quiz everyone afterwards to see if you guys know about the complement system. Talking about the immune response without having had the chance to ever even hear the term complement system is like talking about your back and not talking about that there's a spine in there. So the complement system is the core of our inborn immune system. And what does it do? Have you heard about the coagulation system? Things floating around in your blood. You cut yourself, these proteins get activated, and the end game is I'm going to make a blood clot so you stop bleeding. This is very similar. There's proteins floating in your blood, except they don't detect the bleeding. they detect when there's something in your blood that shouldn't be there, like an invading microorganism. Okay, and that can be activated in a cascaded manner, and the end game is to tell your immune cells, the cellular immune response, get active, get rid of that stuff that's in your body that shouldn't be there. Have you heard about autoimmune diseases? Well, sometimes your body is wrong and detects something in there that actually should be in there and starts attacking that. Very similar concept, can be very detrimental. So I just want to talk about one part of that in the very end, there is a protein that's called C5, just this gray-red protein, of which there's a little C5a cleaved off when it's activated. And that little A makes the whole difference. That, when it was discovered 50 years ago, was called anaphylatoxin. So there was anaphylactic reaction means allergic shock reaction. Toxin means you have too much of that, it kill you. And you can do that experimentally in mice. If you introduce too much C5a generation, they will die. So this can kill you. And this is upregulated in dramatic inflammation. And so this is research that we looked at many years ago. And there's two ways to tackle the C5a, technically. You can either block C5a directly, or you block the receptor through which it signals in the cells. And we have drugs developed for both. The one that I'm talking a little bit today is the antibody called vilobelimab. That is a very safe drug. Antibodies are very safe. We make antibodies all the time, but this one is a monoclonal. That means every molecule looks exactly alike. And it binds this and prevents it from moving to the receptor on the cell and the downstream effects. Okay, we also have a very new molecule called INF904. That's a small chemical pill that you can swallow and that blocks the receptor. That's in development. So that was the educational part. So thank you for bearing with me. So we have developed this antibody and this drug, and we are developing it for different diseases, and we are in development, but I'm speaking about the one part that kind of is a big part of my professional life, which is, if you will, related to sepsis, and that is up here, vilobelimab. There's a trade name now called Göhde, because we recently, a year and a half ago, got an emergency use authorization for the use in very severely sick COVID patients, and we just 2 months ago got an approval, exceptional circumstance approval in Europe for SARS-CoV-2 induced moderate to severe ARDS patients. That's a big step forward for the whole game, not so much for us as a company only, but for the whole game, because it means when patients develop this viral sepsis, there can be therapies, there's others as well, I should say, that address the immune response and make you at least a number of patients survive. And that's something we've been chasing after for so many years, and through COVID now we could prove it with different therapies. And that's why I'm standing here today, because otherwise I had to abandon the therapeutic development in sepsis, because really no one wanted to give development money for that. Investors don't like this because everything failed. Big pharma companies don't like it because everything failed. Some people call it the graveyard of pharmaceutical companies. So when you're trying to pitch a story with, I want to develop a drug for sepsis, the investors smile at you, but mentally they leave the room, right? So that's why you have to find a way. And so that's when COVID came, I came back to the story. This is what I'm talking about today. Is there a role? Is there background? Just a few scientific things. I was part of the discovery team at the University of Michigan, where I met the other founder, Renfeng Guo, and we did a lot of work in bacterial sepsis models in which we blocked this C5a or the receptor. And either way, whenever you did that, you could induce greatly an improved survival. These are survival studies in mice and in rats. And then other people that we were friends with or talked to looked into viral sepsis. For example, here in H5N1, an influenza virus. And you hear that influenza right now is causing a lot of problems again. So bacterial sepsis, viral sepsis, these are some of the groundworks that showed us from a scientific background, there's hope that you can treat maybe also someone with a sepsis and help him survive. But that needs to be proven. Then there was an outbreak of an avian flu, bird flu, in China some years ago. We haven't heard so much about it. It was an H7N9 subtype, but the WHO was very concerned that it could be a global threat, which thankfully it didn't become a global threat, but it killed, a bit over 100 patients, and was a very slow-killing virus compared to the usual influenza viruses. But we got in a program and we tested this drug that I talked to you about, vilobelimab, and this is a monkey model in which the monkeys are infected with this H7N9 avian flu. And you can see that these lungs have very little open air space. There's a lot of cells in there. And when the monkeys were treated with vilobelimab, the airspace is much better, much less cell infiltrates. You see here staining in the lungs for macrophages and neutrophils. So a lot less of these immune cells, which I told you about, which get activated and go into your lung, for example, and cause damage. So this all existed before the COVID story came around. And as I mentioned, we had kind of abandoned, because we couldn't get it financed, the area of sepsis. But when COVID came, we had all this work, all this research already done. And we were sitting there with the board saying, should we do something about it? We were connected to Wuhan. We learned very early, when people here were still not thinking, is this a pandemic or not, that these patients had very high C5a levels. They had, which is a marker of an extreme immune response. So they were septic. They were in full-blown viral sepsis to its maximum extent. And so we decided to do a global study. And I'm talking about that a little bit, but I first want to show you what that means. So you see here, this is an old electron microscopic picture from the Ward lab where I was a postdoc. And you see these arresting neutrophils. This is part of the white blood cells. I call them dirty bombs, right? If you activate them, they can release enzymes, make oxidative radicals. They can get very aggressive. And they can, for example, kill a bacterium, but they can also kill your own cells. It's a very dirty stuff. So these are, when they get highly activated, you get damage to your own tissue. Talking about the autoimmune diseases again, right? What makes your joint hurt in rheumatoid arthritis? It's these cells going in there, getting activated, causing the damage. So you see here that these cells act very, very harshly to C5a. And you also see that they're attracted to the site of infection. They release these dirty bombs, as I call them, and they undergo certain processes that cause even more inflammation. And sure enough, this is a diseased patient, a diseased COVID patient here, where you can see that the vessels were clotted with neutrophils. They were here stained with these green stainings. And they clotted the vessels, the blood vessels, and they underwent a process that caused extreme inflammation. And shortly thereafter, the first group, and it was published by many groups, showed that the more severely sick you were with COVID, the higher the C5a levels. You see that on the right side. So when you developed what we call acute respiratory distress syndrome down here, which is really a form of lung failure, they had the highest levels. So what if you blocked C5a in these severely sick COVID patients? So just want to remind everyone, because you wouldn't believe it, I find doctors all the time that I talk to that don't know this. So it seems intuitive to someone who develops drugs in this space, but they don't know this. So everybody knows that we had vaccines and we tried to prevent this. Before you get infected, that's probably the best thing you do. You get vaccinated, try to have a prevention. And that everybody gets. Some people know that at the very beginning of the infection, you have a very high viral replication. You have a lot of virus in you. And at that time, you're very infectious. You can infect others. And at that time, there are nowadays available some antiviral treatments, but you have to give them very early. If you miss the time slot, the virus comes down, and eventually the patient gets better with some flu symptoms. But then there's these few poor people that develop that immune response, which we here depicted in red. And when there is a certain threshold passed, you can give antivirals. The virus is not even there anymore. When you go here to intubation, the virus may be gone. But your immune system is activated, and that's what's causing your damage right now. So that's really where an anti-inflammatory therapy could kick in, and this is exactly what we did. We went to patients that just got intubated and or put on the lung replacement machine and wanted to see, can they survive better? We did a first study with colleagues in the Netherlands where we immediately got together a group of experts and looked at every patient. It was a randomized study, but open label, so we could take a look every week. We looked all together at every patient chart to try to learn. We were probably the first people on this planet to discover that they have blood clots everywhere. That we enrolled the first patient in March 2020. That's shortly after New York was closed down. I was still shaking hands 3 days before they closed the city down. That's how naive we were. And it's So we developed this hypothesis. In the interest of time, I'm not taking you to it, but I wanted to say two things. The spike up here, the spike on the protein, that causes a lot of complement activation. And when you get C5a, it attracts these orange neutrophils, the white blood cells, I depict them orange. They get activated, they do a lot of stuff. They also increase coagulation, blood clotting, so you get a blood-clotted microvessel that starts inflaming, and then as the neutrophil moves into the tissue, into the lung, all the bad stuff, and that's the damage. Okay, so what happens when you do that on a global study? This was probably the largest one-to-one randomized placebo-controlled trial done in intubated COVID patients. We did that relatively globally, South America, South Africa, Western Europe, and even Russia. It was before the war. So randomized controlled means one-to-one randomized means you put approximately as many patients on the drug as you put on the placebo, and then you follow them up, and you see we gave 6 doses of the drug, and the idea was primary endpoint, can the patients survive better at day 28 and at day 60? And there were some other endpoints, but it was just about can we improve survival. And long story short, this is the outcome slide. This is what we tried to see for so many years in the sepsis setting. Can we separate the curves? We've never seen such separation curves, at least not to this extent, when you go to patients that are that far down deadly disease that they need intubation, invasive mechanical ventilation. And so there was a 23.9% relative reduction of death at day 28 and approximately similar at day 60. And I wanted to tell you this was on top. The patients got everything else. They got corticosteroids, almost everyone, anticoagulants, almost everyone, and even we allowed any other immunoinflammatory treatment, which about every 5th patient got either tocilizumab or baricitinib. These are the 2 other approved drugs in this field. And so this was the basis for the assessment. This was really when more or less everything else had failed, and we gave it to these patients. And so this creates to me a lot of hope. Obviously, you cannot automatically say this treatment benefit will be seen in other areas. You have to research it and prove it, of course. But it is the first sign that you can modulate the immune response in a viral sepsis setting and make patients survive. And just to share, the safety was very well balanced between the groups. You see here, overall, of course, the fatal treatment emergent adverse events were lower in the treatment group because you saw the difference in death, so that's reflected here. But when you look at any treatment emergent adverse event, it was very similar. There were no real, were very comparable between the groups. So the serious related ones were also, this is always something you look for. They were relatively good. And then the infections, they were also overall relatively balanced. One thing peaked a bit out, that the fungal infections were a bit higher, and also the viral infections in the treatment group. Now, these are not corrected numbers, so this group survived more, so these patients accumulated more days on the ICU and in the hospital. So these are not corrected numbers, and we don't know if that's attributable to that, but at least it's in a very tolerable range. So, sorry, we're going to this slide. I have to go back one. We also looked at patients who were the most severely sick, the ones that had, on top of the lung failure, a second organ that was already failing, or the patients that had a lung failure which we call severe ARDS. So those are the ones where you can, with all measures, hardly bring any oxygen back in their blood, or those that had a developing kidney failure. So for all these 3 patient groups that were pre-specified, we showed a treatment benefit that was remarkable in our eyes. This was a pre-specified subgroup for Western Europe. You know, the treatment standards can be very different. US and Europe are Western Europe are very comparable. South America, the staffing at night is already different. South Africa, Russia, you have a very different setup, even though principally you can get renal replacement treatment and everything in these ICUs. But so this effect in Western Europe showed a much larger effect, as you can see here in survival. However, that also must mean that somewhere else it was not so good, and that's true here. For South America, this was driven mostly by one country, by Brazil. For whatever reason, we had a very different age distribution. The patients in the placebo group were a lot younger, 10 years approximately in average. So that could be explained. And last but not least, I want to show you, this is the second last slide. This is something that we just published. It's post hoc. So remember I told you that we also treated patients on top of the other immunomodulators, tocilizumab or baricitinib. Most of them were getting the drug and then still deteriorated, needed intubation, and then they got into our trial and got our drug or placebo. And in this subgroup, this is a post hoc analysis, just to make that very clear, we saw an absolutely remarkable, hardly to explain benefit. This was by and large driven by the combination with tocilizumab. Tocilizumab is a drug that blocks another cytokine that's called interleukin-6. Actually, it blocks the receptor. And we published in the Word Lab that IL-6 is the strongest driver of that receptor that I showed you, the C5AR receptor in sepsis. So there's a connection, and this is interesting research maybe for the future, but this is actually what we all hope. Is there something that when you miss the opportunity, when you're too late with your antibiotic treatment, when your loved one is already in the worst of all shapes, is there something that you can still develop that provides hope? And I'm hopeful, but I still need to phrase this correctly here. This still needs to be shown in clinical trials. This was COVID, this is post hoc, but there's a lot of signals that should give hope for more development. Okay, this was just showing that also the need for renal replacement therapy, which was a secondary endpoint, seemed to be affected. There was a trend here towards less need for renal replacement, because if the mechanism is good for the lung, it should be good for other organs as well, you could argue. And with that, I'm already at the end, so I feel very honored that I could show that. So I came back to a viral sepsis story in my life by having had to do detours. We have now as a company a very big focus on devastating immunodermatological indications. Believe it or not, there's a lot of very nasty diseases in that area with very limited treatment options. So that's currently the main company focus. But I also want to say that our drug has been chosen by the US authorities, BARDA. They're running one of the largest studies ever in lung failure, ARDS. They've chosen 3 drugs to be tested, and we were one of the 3 drugs because of the results here. So with that, a big thanks, a little bit of a glimpse of hope to do more on that science front, but that is not to say that the most important part is to prevent sepsis. Thank you, guys.
Thank you, Niels, and without any further ado, I would like to hand over to another pioneer we have heard in the field of procalcitonin, but as somebody obviously who had learned that there's so much need for diagnostics, and perhaps also this was also a bright idea from him, I think, to combine diagnostics also with therapeutics. We will hear about it a little bit more by Dr. Bergmann, but also by Dr. Witte, who is CEO of one of the companies that derived from this overall group here in Berlin-Hennigsdorf, and you will see more when they start with that. So I could not handle it very good, but you need to click very fast and not keep the thumb too long on it. So that was obviously what I learned on this symposium, beyond some other things.
So I tried. Is it working? Yeah. Yeah. Thank you very much, ladies and gentlemen. Thank you, Konrad, to invite me and Stefan to this exciting meeting. And it's quite emotional for me, so for several reasons. So I hear about procalcitonin. This is a significant part of my life. So I developed procalcitonin in the mid-90s, and it happened here in Berlin. I don't know if everyone knows that. Later we changed the company to Hennigsdorf, which is just next to Berlin. And there I spent the second part of my fighting sepsis mortality campaign. And this is a discovery of new drug candidates for treating shock and mortality in sepsis. So now I hope I will make it. So shock, it's simply the major cause of death in sepsis. So no need to show data or to discuss on that. And so we use the snake, which is a sepsis, and you know, the teeth. So what would happen if the snake would have no teeth? So it would maybe a bit ugly, but maybe not that dangerous. So there are two independent pathways for developing sepsis, and that's the reason why we are two here. So because I will talk shortly about one pathway and Stefan about the second one. So and this is quite new. So this is a result from work from the last, let's say, 10 years, so you can name it new or not. The one pathway, it's the dipeptidyl peptidase 3 pathway, DPP3. Maybe some of you have heard about that, maybe not all. And the other, maybe more known, it's a loss of endothelial function pathway. And these are both completely independent. They could happen at the same time, but mostly they are happening individually. So I will talk about dipeptidyl peptidase 3. So what dipeptidyl, on an overview slide, what happens? So DPP3, it's a proteolytic enzyme. This has been discovered in the 60s, so known since many years. And it was known to be a cytosolic enzyme. So it's in the inner side of the cell, and it's in all of your body cells. In any cell, DPP3 is in the cytosol. So what happens? So you have sepsis, you have infection, inflammation, and that's known also since many years that this may lead to cell death, more or less. It's not specific. Cell death may happen in sepsis, may happen myocardial infarction and other, in burns or traumatic events. So all the pathway I show, it's not specific for sepsis, but it happens in sepsis and is killing the patient or inducing shock. So the dying cell translocates DPP3, the proteolytic enzyme, which is illustrated as a Pac-Man, into extracellular space and into the circulation. And there it acts with very high affinity on destroying angiotensin II, a vital hormone controlling circulatory function. And this leads to loss of control on systemic and local renin-angiotensin-aldosterone system. So the body loses its control on preferring vital organs for perfusion. We have a loss of vascular tone, blood pressure decline, underperfusion of organs, organ failure, multi-organ failure, and subsequent death. So this is quite easy what happens, so and also quite logical. And what I tell you, it's based on highest level of evidence, so this has been investigated, and now almost 200,000 patients. So it's an older slide and published in many publications. It's fully supported by the what we name key opinion leader field. So now what's the solution? So we described the process, but we want to fight mortality. We want to fight shock. So the solution, it's an antidote. So DPP3, it's like a snake venom in the circulation, and you need an antidote. And that's that's an antibody which we name procizumab. And this is a monoclonal antibody binding to the vicinity of the active site of that of DPP3, and is simply neutralizing the life-threatening effect of that enzyme. Instantly, it restores, the antibody restores control on RAS system, induces shock reversal. It has been shown in many preclinical models of septic shock and cardiogenic shock, large animals, small animals, and subsequently normalizes organ function and substantially reduced mortality in all these models. So, and then we decided, okay, now if this looks like that it's an easy mechanism and an easy solution to fight at least a part of cause of shock, so now going to human. So we developed, made the expensive GMP development and things which are not scientifically not so exciting, but it's need to be done. We made it, and recently, last year, we run a safety study, a phase 1A clinical trial in humans, and happily, we found that the drug candidate was well tolerated, so we have not seen side effects. So now Professor Kluge from Hamburg-Eppendorf, so he asked us whether they can check this antibody by this very clear mode of action in 3 patients with end-stage shock, so was named so-called Heilversuche. And this is what happened, as we have seen in animals. So with a single-dose infusion of PCZ, that's the antibody protizumab, we have seen that all these patients, they needed high levels of vasopressor, so very bad circulatory function, and then came back to a more stable circulatory function. And we observed a substantial reduction in inflammation in all 3 patients, from sky high coming to almost normal. And this translates, like in the animals we have seen. I have not shown this data for huge data which we generated in animal models, translates to a very short term, within 1 day, the patients didn't need any more mechanical ventilation, and acute kidney injury changed to almost normal kidney function within 48 hours. So, and this raised hope to further develop that drug. So we have, and that's a plan. So the company name is 144 Pharmaceuticals here in Hennigsdorf. Phase 1 completed, no side effects, well tolerated. We are currently in a phase 2A dose-finding study, which will be completed end this year, and plan then for 26 to 28 to run a pivotal phase 2/3 clinical trial in patients which are DPP3 positive. So first we measure DPP3, so they need to have shock. DPP3 measurement must be positive, and then they get a single dose treatment, and the primary endpoint is mortality. So, and with this, I hand over to Stefan, who is dealing with the endothelial function. Stefan.
So I will speak about the endothelial dysfunction pathway, and just to briefly introduce the endothelium. So that's the inner layer of our blood vessels. It's a smart barrier in the blood vessels because the endothelium controls what goes out of blood and what goes into the blood. So this is oxygen, nutrients, toxins, hormones, whatever. And so sepsis can create leaks, holes into the endothelium, and this is the other relevant pathway in the pathophysiology of septic shock. And one of these causes include the dirty bombs that Niels just introduced. And the cascade of events is, so sepsis, inflammation, is causing leaks to the endothelium. This will lead to vasodilation, edema, tissue and organ perfusion is compromised. We see organ dysfunction, we see multi-organ failure, shock, ultimately death. Then there is adrenomedulin. Adrenomedulin is a vasoprotective hormone that can actually mend, fix these holes and leaks in the endothelium and protect it from further damage. So this is a part of the body's own response to fix the situation. And adrenomedulin, its role as for DPP3 has been validated in many clinical trials. And patients with elevated levels of adrenomedulin, we know, have a much higher risk of dying from sepsis or septic shock. Adrenomedulin is not only an indicator or a measure to determine the risk of a patient, it's also an attractive pharmaceutical target. And the drug we are developing at Adrenomed, also in Hennigsdorf, is enibarsimab, originally invented by the gentleman here to my left. And enibarsimab is an antibody that can bind to endogenous adrenomedulin and basically enhance its function. So it's extending its half-life from minutes to hours to days, and the action of the enivarsimab adrenomedulin complexes, they can improve the function of the vascular endothelium, decrease vasodilation, and treat septic shock. I do spare you all the scientific details. Feel free to ask me over drinks. I will just show you the key finding of our first patient clinical trial, which is very encouraging. And here you can see patients with septic shock, the most severe form of sepsis we are seeing. They have typically a 30 or even 40% risk of dying or not getting alive out of hospital once they are in shock. So in our clinical trial, the patients receiving best standard of care had a 24% probability of dying from the condition. If we add enivarsimab to the treatment, this goes down to 8%, and that's very encouraging. And we have completed phase 1 testing. We have completed a first clinical trial. We are currently preparing for a registration trial, for which we are also currently in the fundraising process. And this is already the end of the enivarsimab story here. And I just, in order to summarize, so with prosisumab and enivarsimab, we have 2 novel, highly promising drugs available. They are both targeting separate pathophysiologies of septic shock, and both drugs, they come with a diagnostic where we can, from a blood sample, within a few minutes, make a decision which patient is most likely to benefit from one drug or from the other. And with this, we hope that sepsis, septic shock can become much less daunting. And I wanted to convince you that there are new treatments on the horizon. There is hope on the horizon. Just a last remark. We do not only need to bring sepsis and septic shock to the attention of the policymakers, it's also, as Niels already mentioned, bringing to the market treatments for sepsis and septic shock is not a priority of pharmaceutical companies. So if you look at the back end of this flyer, you see none of the top 50 or top 100 pharmaceutical companies. And it's sad to say that probably obesity, genetic hair loss, erectile dysfunction, and wrinkles in the face have a much higher priority for pharmaceutical companies than treatments for septic shock. Thank you very much.
I could not agree more on your last sentence, and I want really also to congratulate you that you did not give up, and both in the field of developing diagnostics, which was a long story, and also not to give up in the development of potentially helpful immune modulatory therapies. So, and this confirms one of my learnings over the last decades, that the difference between success and failure is persistence, and hopefully we will have at least, if we would have 5% investment in what has been invested in HIV, in cancer, and in cardiology, I think we would be already there, but I'm convinced more than ever that we will get there. So last but not least, because we have one issue in the field of sepsis, that we have big debates, we have difficulties to understand the burden of sepsis. What you have heard from the Global Burden of Disease report is all based on numerous assumptions. We have made much progress because 15 years it was not at all mentioned, sepsis, in the Global Burden of Disease. And Dr. Dastur from Diplo is one of those companies who is working to compensate that we don't have electronic health records in Germany, which is the case in the US. That's because in the US, they know better data, and they have demonstrated the incidence of sepsis. And we are working also as Sepsis Foundation with them to encourage them to get better in the continuous assessment of the burden of sepsis, but also, and you won't address this, at the same time you are working on early recognition on the basis of AI, and that's another very important angle of your work. The floor is yours, and thank you so much.
Thank you. Yes, dear ladies and gentlemen, dear Professor Reinhart, dear Mariam, I'm very pleased to be here. It's a great honor to be part of this event, so thank you for the invitation. Yeah, my topic, as has been introduced, is a little bit different. It's about EHR, data, and artificial intelligence. This is the current situation in most hospitals, at least in Germany, but I'm sure also many other countries. A vast amount of medical data is being collected in different systems, but most of these systems do not communicate adequately or efficiently. And in fact, this lack of communication and interoperability it obstructs or at least limits further data analysis or research. And of course, the solution is more interoperability and standardization of data. This is where we come in. Our company is kind of specialized on bringing interoperability to where you have usually no standardized data, and in a very complicated process, we read data from the silos in the hospital, and then we map the data we get to national and international standards, for example, LOINC for lab results. And as a result, we get an interoperable patient file that can then be used for further processing and research. So what are the actual use cases for the patient file? We can use this patient file, for example, to support expert systems or even power AI agents. A good example would be automated letter writing in hospitals or process optimization. And we can also aggregate different data pools of different hospitals into large networks, big data, for machine learning training. And this is actually what we do in the past years. We have managed to build up a large machine learning network in collaboration with more than 140 hospitals in Germany, including at least a third of all university hospitals in Germany. Our machine learning network contains more than 10 million highly pseudonymized, well, virtually anonymized medical case files, and of course all of it in accordance with data protection laws and requirements. And the network contains fully representative data. Here we have, this is just one example, but it's a comparison with data provided by the Federal Statistical Office of Germany, and as you can see, the data is practically identical. But this is important because in contrast to the official data that you can acquire, our machine learning network actually has more detailed information. Our network contains lab results, written notes, and so forth that can be used for further analysis. So what does it actually mean for sepsis? In collaboration with Professor Reinhart and colleagues and experts of the University of Jena, we developed a sepsis label because big data is just one element. Another crucial element is actually a robust labeling. It has to be scientifically correct, and then you bring both together, correct labeling and big data. And for that, we developed a sepsis label. I don't want to go through all the details of this slide, but in a nutshell, of course, our sepsis label is based on the sepsis 3 definition. It also includes recommendations by the CDC. The sepsis definition has a more medical focus, and the CDC recommendations also include some technical recommendations. And then we had to make some very specific adjustments on our side that were required for our data environment. And you see the label has many layers, and once the label was validated, we applied it to our machine learning network on a national scale. And these are the results. This is unpublished data, and it's just a sneak preview on a smaller sample. It's an analysis for 17 German hospitals, including a total number of 1.5 million cases. And in that number, we can find about 28,000 cases with sepsis ICD codes. This is also the results we get from the official statistical office of Germany. In contrast, our sepsis label finds twice the number, which further supports our suspicion that sepsis is vastly underrepresented in official statistics. If you take a look at the incidence levels, you can see that, of course, we have higher incidence with our label, and interestingly, we also see an increase starting in 2019. And one explanation is, of course, COVID-19 and COVID-associated sepsis, but also a growing number and increase in digitalization. The more digital data, the better results. This is also, it aligns with the results reported by RE in 2017. That's a groundbreaking paper, and it's also the basis for the CDC toolkit that I showed in the slide before. And we can see that our results are pretty similar to what RE observed in the US between 2009 and 2014. When we take a look at the mortality rates, you can see that we actually have a flip in the graph. We have a higher mortality in the claims data, while our label shows a lower mortality, and the most obvious explanation is that sepsis cases with less severe progression are actually not reported. They're not seen, they're not detected, and hence they don't show up in the statistics. And this too, again, aligns with the observation of RE, because as you can see, the explicit sepsis codes showed a higher mortality than the clinical data. So what does this show us? I mean, us as a tech company. It shows us that our algorithm is working pretty well, so we can take the next step. What you see here is a patient's hospital stay, from admission to discharge. And from the very first moment, a lot of data is collected. Lab results, all kinds of results, written notes, and so forth. And at a certain point, there is an onset event. The patient becomes septic. And ideally, in the best case, we have an offset event where we have a successful treatment. So we can divide the hospital stay theoretically into 3 phases. We have a pre-onset phase, a post-offset phase, and then time in between which the patient is septic. What we want to find is this onset event. So our label is designated to find exactly this moment, because then we can use the label to actually detect sepsis out of the HR data. And we can also train machine learning models to find this exact moment to predict sepsis cases. What we don't want to see is alerts in this area, because that does not make any sense. this is what our machine learning model looks like in a real CDS software. In this case, this is our software. This is a real patient. These are real life data collected in a hospital, and you see that the patient was on ward, and at some point there was surgery, and after surgery the patient was admitted to the ICU. That's why we have much more data because of the monitoring. And then we have no laser pointer, but as you can see, there is a warning, a risk prediction. Our system says that this patient does not seem to have sepsis right now, but there is a high risk for sepsis. And this is explainable data, so all features actually processed by this machine learning model are shown to the doctors so to help them interpret this warning. And what's perhaps more important is this little number here, 14 times. Our system sees a 14 times higher risk for this patient in comparison to the average patient, so that it is fully justified to show this warning to the doctors. Oh, here is also an English explanation, but this is not, this is, well, it's not causality that's depicted here. It's not medical causality, but it's a correlation analysis. That's how AI works. But still, what you see here can be very helpful in a live setting at the point of care and help the doctors to interpret these warnings. Our model has very good, it was trained on 3 million case files and has very good metrics in automatic validations. But to be honest, this is not what matters. What really matters is the performance of machine learning models in a real-life setting, patient-centric and patient-specific. That's why our doctors validated in the course of a few weeks prospectively more than 80 alarms in 83 patient cases. And the result was that almost 80% of the warnings were perceived as very helpful and appropriate. Appropriate in terms of medical correctness and appropriate in terms of timing. So the warning came to the right timing. And this is also supported by what we see in literature. There is not much literature about this because it's a new technology, but there seems to be some evidence that machine learning is perceived as positively by doctors and that it may improve some clinical processes or even the treatment. But we see that large-scale randomized trials are needed. And therefore, we will start a randomized trial in collaboration with the University of Schleswig-Holstein. It's the second largest university hospital in Germany after Charité. It will start in March or April and will include more than 30,000 patient record files. And we are very excited and very optimistic. And to sum it up, I'm not going through all of this. I think the message is clear. Digitalization and interoperability is essential, and new technologies will help. It may be machine learning, it may be generative AI or some new innovations, but we need digital data, and we urge decision makers, politicians, hospitals to do more for digitalization and interoperability. Thank you. Thank you.
This has been a truly full day, full of emotions, full of anger that so many pain and stories could be prevented. But also, I think, full of hope, because what we see how our amazing sepsis survivors have overcome the most challenging times, and not once, but multiple times in some of the cases. and they have become the true warriors to protect others. That's something that we can only admire and be grateful for you for being with us today, despite still very young period for the grieving, or the pain that you will never be able to recover, and the life will never be the same. But thank you for helping us to reach out to public, media, policymakers, because without your voice, we would be just, another association, maybe professional association, really speaking about complicated medical terms and really being in our bubble, but not really able to make the impact that this field is really looking for. And I truly believe, together, uniting the forces of academicians, innovators, survivors, and the families, we definitely can win this game. It may take time, but we will definitely be there. And maybe in the snake year, we could have some breakthroughs very much needed. And it was true, Andreas and Stefan, you mentioned that there is lack of investment in private sector and the lack of interest from the private sector companies. But looking back to like 50 years of global health history, UNICEF would never be able to achieve the child immunization goals unless the private sector would have been motivated by the governments or global public-private partnerships to make sure that those vaccines, after the research and development, would have low cost, accessible, and reaching millions of children. The same happened with antiretrovirals for HIV. AIDS. The same happened with directly acting agents for hepatitis, with a huge R&D investments, but currently something that was costing $80,000 per regimen is now accessible for less than $1,000. So that's exactly what we need. The private sector left alone to invest in sepsis will never succeed. We need funding from private major foundations, and that's why we need to unite also our voices. So in the conclusion, thank you to every single amazing speaker. And we really wish that each of you had more time to elaborate and to learn from you. But I think this was one of the best events we managed to put together. Thank you very much to the sponsors. Without your support, even this tiny meeting would not be visible. And of course, immense thanks to Bill Pullman. Without him, we would not be here together. And we really hope that this is the beginning of the new chapter in our common fight. And let's see. It all depends on us. Graduating from the Harvard Kennedy School, there is this amazing phrase by President Kennedy: "It is just us." Sometimes when you have the major challenge, you think that someone will take care of it, someone will solve it. No, it's just us. We have to do it together. So, yeah, I mean, with this consistent commitment, I'm sure we'll do it. And of course, special thanks to our brilliant teams in the Global Sepsis Alliance. Katja, Marvin, Simone is not here, and an amazing team from Sepsis Stiftung. Stefan, Mariah, Heike, who is not here today, and the leadership of Ilona. And yes, thank you so much. Okay.